This workshop would not have been possible without the blessings and the vision of our revered Honorable Founder President Dr. Ashok K. Chauhan sir, and the unwavering support and leadership of our Honorable Chancellor Dr. Atul Chauhan sir. We are also deeply grateful for the inspirational guidance of our Honorable Vice Chancellor Ma'am, Professor Balendra Shukla, whose commitment to academic excellence continues to shape our direction. Our heartfelt appreciation also goes to Honorable Senior Director Dr. S. Srivastava sir, whose mentorship and encouragement have been invaluable. We also acknowledge with gratitude the academic leadership of our Dean, Professor Dr. Jayanti Pujari ma'am, and the consistent support and vision of our Director, our Vice Honorable Professor Dr. Kalpana Srivastava ma'am. Without whom this CRE would not have been possible. A warm welcome to all of our respected faculty members, valued colleagues, and our bright and enthusiastic students. We here gather for this academic event. Now it is my profound honor and privilege to welcome our distinguished guest speaker for today, Dr. Prasanta Kumar Roy. Sir and ma'am, can you please join us on the dais? Please help me welcoming him. Dr. Prasanta Kumar Roy, sir, is the head of the Department of Clinical Psychology at the Institute of Psychiatry, a center of excellence Kolkata. His remarkable ability to bridge academic rigor with compassionate real world application stands as an inspiration to clinicians and scholars alike. His contributions to the disaster and mental health, clinical psychology, and community-based interventions are widely recognized, and we are privileged to have him with us today. Dr. Roy brings a depth of academic and field-based expertise with over 16 years of teaching experience and an active involvement in disaster mental health interventions across India since 2001 as a volunteer, as a felicitator, as a community-based trainer on psychological first aid. He has contributed over 37 research papers, served on editorial boards of reputed national and international journals, and is a recognized voice in the areas such as IBT, CBT, hypnotherapy, and psychosomatic medicine. A past president of the Indian Society of Clinical and Experimental Hypnosis, Dr. Roy is also an active member of the Disaster Mental Health Committee of IACP. I would now like to invite Dr. Professor Kalpana Srivastava ma'am, Director of IBAS, to kindly welcome sir and to felicitate our esteemed guest speaker for the day. Thank you so much. Thank you so much, ma'am. So please accept our heartfelt appreciation and present of token of gratitude. Thank you so much. So with that, I would now like to call, and it's my honor and privilege to welcome our keynote speaker for today, Ms. Rashmi Pandanan, who is an assistant professor and assistant director at IBAS, a brilliant academician and a seasoned clinician. Ms. Pandey brings with her over 18 years of rich experience in the field of mental health. She is also a proud member of Indian Association of Clinical Psychologists and has continually contributed to the academic and therapeutic advancements of our discipline. Her ability to weave clinical insight with academic excellence makes her sessions deeply engaging and profoundly impactful. We are delighted to have her with us today and look forward to the knowledge and perspectives that she brings to us within this forum. Ma'am, I would like to kindly welcome you. So over to ma'am today. Thank you. A very warm good morning to all of you and our guest speaker as well. So, starting with today's topic, that is interpersonal therapy for couples. So, since yesterday, we have develop an understanding of the key aspects of interpersonal therapy and how it is implicated in depression and anxiety as well as grief. So today we will try to understand how this IPT conceptualization is implemented in the couple context. So before starting, let us first understand what do we mean by the concept of interpersonal behavior within the couples. What is it? It is reciprocity of focus on the self as well as the other. That is giving values to myself as well as giving values to my partner, a balanced approach between the two. So it has to be in the context of an adequate amount of connection as well as separateness between the partners. And any deviation from these relational patterns may contribute to a relational pathology. What are the dimensions of any healthy interpersonal behavior is affiliation and autonomy. When we talk about affiliation, we mean the degree of friendliness and versus hostility. And when we talk about autonomy, what we are trying to understand, the degree of autonomy to be the way I am within a relationship and at the same time, the enmeshment of the relationship. So there are two dimensions, both positive and negative dimensions of each components. So a balanced approach of the both is very much required for the healthy relationships. And when there is a digression from these concepts or these behavioral patterns, then where there is a problem sets in or a dispute sets in. So why there is a need to address couples? Definitely, nowadays, where we are going into this 21st century, there is a higher evolution of a higher expectations of a much more dignified, respectful, full of autonomy expectations of the partner-based relationship. Whereas at one point of time, there was a thought process, traditional approach and a thought process that tolerate, try to understand, just submit and be in the relationship. But now there is a very strong shift and both the partners where they are evolved individuals, they look forward for a mutually dignified autonomic relationship. So definitely today's couples have much higher expectations from the relational life, number one. Moreover, partners, if they themselves are in a distressed relationship, it is bound to lead to a development of number of psychopathology, maybe depression, anxiety. In some cases, it may lead to substance abuse. And not only the impact is going to be in the couples, it may percolate to the children and the family as well. So there might be a deleterious effect on the mental and physical health problems, poor academic performance, and variety of other familial concerns in the family context. Now coming gradually to the point that since IPT primarily was conceptualized for depression, so IPT in the conjoined form, that is in the couples form, has also been conceptualized when one of the partners is undergoing depression and how the other one the partner can assist in the process of change and recovery. So from understanding it from that lens, interpersonal theories of depression suggest that dysfunctional interaction underlie both depression and relationship stress. Now, these individuals who have, when one of the partners have depression, usually a particular kind of longitudinal, reciprocal, negative communication is something that has been observed. Moreover, there is a persistent pattern of conflict, emotional distress, and various transitions within the life. Now, from the interpersonal lens, when we try to conceptualize the interpersonal behavior of the couples, these are the marked facets that has been identified over a period of time. And these concepts very well align with the objectives of IPT that addresses role transition, role dispute, any kind of a grief, loss, and so
we need to understand, we need to conceptualize the difficulties in the relationship. If it fits into this lens, then we can move ahead with the conjoint interpersonal therapy. So let us understand what is conjoint interpersonal therapy. It is specific treatment for clinically depressed partners with marital disputes. And what is the basis? The basis is that if there is a confident relationship, then it will act as a protection against the depression. So we need to understand why the partners need to be included in the therapy. Because IPT has been conceptualized for depression at an individual level, right? But when we have an understanding that the depression is stemming from the fact that there is a dispute between the partners, or that there is a major life transition where one of the partners is battling single-handedly, and then when the therapy has conceptualized, the need can be understood whether a partner can be brought into, so that both can work conjointly to bring a change in their interpersonal dynamics and processes. And that's the reason it is said that a good, confident relationship between the partners will be a protective factor against depression. How does the model works? Rather than solely treating the individual IPT conjoint marital relationship, it focuses on the couple as a unit of change. Therapists help partners identify their interpersonal interactions that may contribute to their distress. The kind of interpersonal interaction that the couples are having, that we will discuss in detail a little more. And then gradually the therapist help in renegotiating the role expectations as a means of reducing the symptoms. So if there is a role dispute, first identification, what is the dispute? What is the nature of communication with regard to that dispute? How they are trying to handle it? That identification and understanding, and then gradually the therapist help both the individuals to develop insight, what is the faulty pattern, and then how they can bring a change and make a change in their role and relationship. So therefore, the primary focus is achieving sustained change through helping couples gain a richer understanding of their problems in their relationship. So now, particularly when we talk about conjoint interpersonal therapy, most of the researchers has been done in postpartum depression. Because postpartum depression is a scenario where the partner goes through a major change in life, and then the partner's perception of social support, the partner's perception of receiving cooperation from the partner, from the family, the perception I'm talking, makes a lot of difference at that how she is going to cope with this role transition. And if things doesn't fall in the proper line, then the difficulty starts. So let us have a brief understanding of postpartum depression. What are the risk factors? So the risk factors for postpartum depression has been depressed mood and anxiety during pregnancy, personal and family history of depression, exposure to stressful life events, particularly during the pregnancy period, lack of social support, and quality of the woman's relationship with her partner consistently emerges as a risk factor. And it has also been seen not only the bad quality, but at the same time, the extent of the bad quality now also determines the intensity, the duration, and the risk for relapse for depression in women partners. And how does it impact? It impacts the life of the women, definitely. Then it also impacts how the woman is going to form a secure attachment with the child. That process also gets impacted, as well as staying in an unhealthy environment along with the depressed partner. The counter partner may also develop certain kind of mental health issues. So that also needs to be looked into. And male partners of women diagnosed with clinical depression following childbirth has reported higher levels of anxiety and depression. These are all the accumulated research findings over a period of time, and greater distress in their relationship with their children and partners. So maybe the women partner, the individual who has given birth to a child might be undergoing depression, but it has a spiraling effect on the partner as well as on the children and other members of the family. So now coming to, just give me a second. So now we need to understand how conjoint interpersonal therapy has been conceptualized and divided into phases. So basically, when cases have been taken up for conjoint interpersonal therapy, it is basically divided into three phases: initial phase, middle phase, and end phase. So conceptually, 90 minutes duration of each session has been proposed across 12 to 15 sessions. We all know that it is a time limited therapy. So 12 to 15 sessions of each 90 minutes duration has been proposed. Though in our practice, we do tend to tweak here and there a little, but since it is a time limited therapy, we need to keep the essence right when we are dealing with IPT therapy. So the initial phase is consumed in gathering as much as information as possible. So since we are addressing, the IPT therapist is addressing both the couples, the initial 4 sessions are addressed for the initial phase of the therapy. The 2 sessions with the couples, that is session 1 and session 4, is the information is gathered when both the couples are both the partners are present, and one individual session with each of the partner is taken separately. And what all is focused in this phase? Providing psychoeducation about PDD, linking postpartum depression to relationship stress, clarifying the therapeutic contract, assessing the mental health functioning of the partner, definitely of the mother as well as of the partner, conducting interpersonal inventories, exploring relationship models, we'll be dealing with each of them in detail, exploring the history and current conflict in the relationship, and assigning the dispute list. So before moving on, can you please, any one of you can help me understand why psychoeducation about postpartum depression is important when we are starting with conjoint IPT? Anybody? So in a couple's dynamics, when a lady is coming to you reporting certain difficulties and you are identifying that to be as a condition of postpartum depression, and you conceptualize that the partner needs to be included, then the first step that begins with is, even before we start collecting other dynamics of the relationship, the first part that starts with is the psychoeducation about postpartum depression. Why is it necessary? Please.
Or thank you. It's not really identified as something that actually happens with a woman after she becomes a mother. The awareness is very low. And as soon as she becomes a mother, she is expected to take charge and start, becoming the first caregiver for the child. More or less, it is her responsibility end to end. So the psychoeducation right at the beginning is very important, in my opinion, so that there is complete awareness about in both. In fact, even women find it difficult to recognize it, even if they are, experiencing symptoms. Exactly. So it's very important to give a name to those symptoms and explain to both the partners, the mother and the father, that this actually happens. This is real. It is not something that is imagined. And it is very important to understand that it will affect both of you. So I feel that this is a very important step right at the beginning, even before we start collecting information.
Wonderful.
Thank
Yeah,
you.
you have correctly explained it. So basically, after identifying the patient, that is the women partner, and understanding her current symptoms and leading to a diagnosis of depression by the professional, both the partners needs to be included in the psychoeducation process. Now, as the way she rightly pointed out, that even if the patient might be undergoing the symptoms, she may not be realizing what it is, and the other family members, particularly the partner from whom she is seeking the support, may not be understanding what the individual is going through. They might just be understanding now she is the mother and that is the traditional role that is expected out of a woman mostly, that she is the mother and she needs to take care of the children, as well as there will be a continued cycle of other familial responsibilities. But how it is impacting her and how with this role transition she is finding it difficult to cope with the added responsibility is something that needs to be highlighted in this psychoeducation part, number one. And number two, since there is an added symptomatology of depression that further is making it difficult to perform her the required roles, is also the partner needs to be sensitized about. So, and at this time, assigning the point that the individual who is undergoing depression is the person who is sick, and that she should be, she should be temporarily released from her daily routine, from her obligations, so that she can work upon herself and work upon her recovery. This needs to be highlighted, and this should be a very, very important component of psychoeducation. So it's not that the individual is coming for the therapy, but again going back, she is again doing the same chores. So there is no differentiation. So differentiation has to be established that now she is not able to cope. She requires extra support. She needs to work upon herself to recover. So as a result, she needs to be released from the social obligation of taking care of the family and as well as the child. With regard to the child, to some extent it may be there, but not in totality. And also highlighting that this major transition from being a couple to parenthood is a major adjustment in life, and as a result, there is a probability, there are biological reasons, there are social reasons that might contribute to the depressive phenomenology within the individual. So the partner also need to get the postpartum depression in the context, that how and where it is linked and how it is impacting the current mental health of the partner, as well as how it is indirectly impacting the entire family functioning. So that component of psychoeducation is very important even before we go ahead with the collection of all the relevant informations. So now when this happens, what happens? Maybe till the time the partners are coming for the therapy, they have already started blaming each other. They have already started saying that you have changed, you are not able to give me time. Both of that, they might not be realizing what they need to attribute it. So that attribution has to be set clear over here. And in a way, when the psychoeducation is done, to some extent, the diffusion takes place. The validation of the emotions that what they are experiencing is true and it is not comfortable, and at the same time the tendency to blame each other gradually reduces and diffuses. So that the collaboration that we will work together to understand our difficulties and how we need to address these difficulties, that collaboration and cooperativeness has to be elicited, and that is done only when we are able to psychoeducate them adequately. Linking symptoms to relationship distress. So obviously, depression in any individual, there might be myriad reasons, but for all those myriad reasons, we are not applying IPT. We are applying IPT only when we are trying to conceptualize depression in the relationship context. So once again, the therapist needs to reiterate that how the relationship differences, disputes, or distress, how the unhealthy pattern of relationship is contributing in a cyclical way to the depression that the women is experiencing. So in conjoined IPT, there is a presumption that the primary problem area is role dispute that has been identified over a period of time. And then the relationship conflict needs to be understood in the context of transition from a couple to a parent in which roles. Earlier, they were just partners, they were free to do, they had their own sense of order. They need to rewind their entire schedule, right from getting in the morning to sleeping at night, and adjusting each and every dynamics of their daily life as per the child's routine. So that needs a lot of renegotiation. More so in the context of nuclear family setups, these transitions are the major reason of creating a havoc in the couple's life. So in the process, we need to understand that relationship conflict is considered in the context of transition from being couple to parent, and that the couple is going through a process of renegotiating social roles with shifting responsibilities and expectations. Responsibilities towards the child and expectations between themselves. Now, establishing how depression stems and result in relationship distress. So it's a pattern. So it's not that the relationship is the impact of the role dispute. It might be the reason also, and it might contribute also to the dispute. So it needs to be understood from both the perspectives. So establishing how depression stems and results in relationship distress helps support the rationale for a conjoint IPT, and simultaneously addressing depression and the relationship issue. Am I clear till this point? Now, there comes the point of clarifying the therapeutic contract, like how the therapy will proceed from here on. So the therapist communicates about the number of sessions, the length of the session that I already shared. Approximately it is of 90 minutes, and from somewhere from 12 to 15 sessions. Goal of the therapy is to alleviate the depression symptomatology, as well as parallelly improving the interpersonal processes, improving the relationship of the couple. So that two-point agenda needs to be met over here. And what does the therapist communicates about his role? Because that part also needs to be clear with the couples, that the therapist is there to be an ally to both of them. So, and whatever discussion will happen, it will be through an open channel, and it's not that therapist is not going to speak on behalf of someone else. Because at times what happens during the process of interaction, one of the partners may have a tendency to try to develop a extra edge with the therapist, extra bond, and try to navigate his or her requirements through the therapist. So the therapist has the responsibility of distancing himself or herself from this triangulation part, and the only philosophy that therapist needs to imply is that there will be an open communication, okay, and minimizing the possibility of triangulation. Even if the therapist senses as a tinge of effort from any of the partners to develop a specific relationship with the therapist needs to address it then and there within the therapeutic context, directly, politely, directly, that this has to be an open channel communication, and we all three need to work together, and we need to minimize the triangulation part. Now, since the Since the initiation of conjoint IPT, we all know that we are dealing with an individual who is going through postpartum depression. We have identified, we have diagnosed. Now, what about the mental health condition of the partner? How prepared is the partner impacted in any way because of the other partner's mental health? Number one. And if the partner is impacted, then that also needs to be addressed, because to elicit adequate support and cooperation from him to address the relationship distress of both of them. So assessment and understanding of the mental health scenario of the partner is also important. It's not just that we are dealing with the depression of of a pregnant lady. It's not just restricted to that part. Assessing of both the identified patient symptoms and of the partner's mental health. Uncovering the emotional functioning of the partner is significant, as he may require treatment, and this may impact the ability of the partner both to change and to assist in the recovery. So he needs to change himself also if he is undergoing some mental health issues, and at the same time, he needs to play an active role as an agent of recovery from the perspective of relationship dispute that the couple is experiencing as of now. If the partner appears to have mental health issues, the clinician discusses how commonly this occurs among the partner of the women with PDD and explores how the partner addresses these difficulties. So where there has been a history of mental health issues, and if it has been there maybe in a recurrent pattern, what steps have been taken till now to address those? If steps have been taken well and fine, then need to be continued or escalated further. And if not, it needs to be started parallel. That may be ranging from taking medications to therapy, individual therapy as well. Of the partner, of the individual. So as I said, that we know right from the start that we are dealing with a lady with postpartum depression. Now we are seeking including partner also to assist in the therapeutic change. But we also need to understand the mental health concerns of the partner as well. Because if the partner has some mental health issues, then that will impact the process of change and recovery. So a detailed understanding that what is the mental health status of the patient's partner, identified patient's partner, is important to understand whether it needs to be addressed, whether it is fine, if it needs to be addressed, whether it has already been addressed, or whether it has been identified and understood for the first time, and then maybe what next other things can be done, so that if his functioning is adequate, he will be and he will be able to collaborate and contribute better to the relationship change of the current scenario.
Ma'am, in the due course, if we find out that the mother herself is also, going through some other conditions, is experiencing some other mental health conditions. So in that case, which were probably not addressed before, right? So in that case, how do we, what should be the approach and what should be the steps taken to address that? Because it's obviously going to affect, her condition further. So in that case, what do we do?
See, if the woman herself is also has been suffering from some other mental health conditions, if there is then we need to understand from the entire historical pattern, taking some medications, if she has been undergoing some counseling or therapy separately for those conditions, and if those conditions are helpful in bringing a change into it, then it needs to be continued as it is. Because over here, we will be focusing only on the relationship aspect.
If there is a condition and it has not been identified,
then we need to work, the therapists need to work around it and help her in identifying and then make a suitable referral for the same.
Thank you.
Okay. Now coming to assessment, when we talk about interpersonal inventories, we need to understand the social scenario of each individual, that is of both the woman as well as her partner. So we need to gather information about the past and present interpersonal world of both the members of the couple. So we may be giving some this interpersonal circle, and we will ask each of the partners to fill so that we can get a view of their past, present, social circle dimensions. And how does it help? It helps us understand their relationship pattern outside the therapy, like who is there in the closer circle, whom they perceive to be very close to them, whom they perceive to be a little distance, whom they perceive to be an extended support, whom they perceive that they are totally out of the radar and they are of no relevance to our life. So, and what kind of equations do they share with each individual? So, we need to take detailed understanding and from both the partners separately. So that will give us an idea about not only about their relationship, but how do they deal with the relationship out of this present interaction that they're having within the excuse me. It also suggests their areas of conflict that may arise both in and out of the therapy, and it gives an understanding to the therapist of their potential social support. What kind of a social support? To whom is the individual, the identified patient is close to whom is her partner close to, and then whether they can be of any help further in resolving their interpersonal difficulties. Along with the social connections and social support, next important information that needs to be elicited is the impact of the postpartum environment on the members' relationship with the others, right? Because since there is a birth of a child, there is a change in the family environment. How many family members are there? How each one of them are relating to the child, and how then post the birth of the child, how they are relating to each other also needs to be identified and elicited. Asking questions about the ways in which the birth of the child has affected the relationship. What expectations of support was discussed about prior to the delivery, and what is the identified patient's perception of support. Like what all was discussed, who will be there, who will take care of me during my pregnancy, who will be taking care of me during the process of my delivery, who will be there to take care of my child when I'm still recovering from the impact of the operation or the heavy doses and from the weakness that I have experienced. So what all has been thought about how who else will come and play a role in this period. That is something is usually discussed, should be discussed. Whether it has been discussed or not is an important aspect of eliciting information. And then the main point, what is the identified patient's perception about this support? Does she perceive that she received the adequate help? Does she perceive that she accumulated required amount of social support? Because her perception will determine whether she holds the resentment towards the same or not. It's not what has been provided. What has been objectively provided and what is identified patient's perception about the provision of support that she has received. That will make a difference. And also how each of the couple or each of the partners are connecting to the child also, and how do they connect to the other children within the family. If it is a joint family setup, or if the couples themselves, they have other kids, what is their relational pattern? So that means what amount of time they are spending with the newborn, how they are trying to spend time with the newborn, what is the way that they have been connecting to the other children in the family. That will give a understanding of their psychological makeup of dealing with or interacting with children. Inquiring about the interpersonal relationship of each member with the newborn. Information from each member of the couple about the amount of time spent, kind of activities engaging with the children or the child, perceived effectiveness of comforting the child. Like if the mother is engaged and she expects the father to take care of the newborn child. Maybe the child is crying, maybe they need to change the diaper or they need to feed him, whether he is effectively able to do it. So, whether he is doing it or not, number one, and whether the way he is dealing with the child is producing the required amount of comfort in the child, because the more the child is comfortable, the more the couple will be also at peace with themselves. So that perceived effectiveness, whether the mother is able to perceive, because she has been tagged with the primary responsibility of taking care of the child, right? So, and she is undergoing depression, she is seeking support. So how, whether she, with the way she is perceiving the father is able to help, and vice versa, whether the father perceives that the mother is with her condition is able to take care of the child or not. So that perception, once again, vice versa perception, understanding of the perception is very important. And definitely, once again, our understanding of the expectations from parenthood. What changes needs to be done? How do they need to accommodate with each other to take care of this bigger role that has been assigned in their life? Now, till this point, we discussed about their understanding about their social support, their interaction with the child, their interaction, their expectations towards each other with regard to the rearing of the child, taking care of the child. Now, the next set of information that needs to be that is required to be accumulated is exploring the relationship role models. That means who has been the role model in their own life while they were growing up. How have they perceived their own parents while dealing in the child rearing practices? How they have been how they have been addressing the conflicts. So each partner's understanding of their parents or significant others in their life, how they have been dealing with certain conflicts, will also play a role in their present life, because they are taking the essence from their role models in dealing with their present life, present difficulties as well. So each member's relationship role model, what has been learned about relationship from their parents or significant others in terms of affection, the display of affection, conflict negotiation, communication, and division of household responsibilities. So suppose if a father who has been born and brought up in a setup where they has never seen his father taking care of the child or even addressing the basic emotional needs of the child, they might be immune to the whole idea. It's not that that they are intentionally not becoming a part. They do not have the sensitivity. They do not have an understanding that I need to play a role. So maybe the dispute may be at this minor level where educating him that you need to play a significant role, you need to provide a support, may also be it may play a significant extent to which the individual might be helpful in the resolving the disputes between the couple. So, exploring this, their own understanding, the partner's own understanding of conflict negotiation or communication or their respective roles in the division of household responsibilities goes a long way in understanding how the present scenario can be addressed. So as I have written an example over here, if one person has witnessed one parent regularly acquiescing to the desires and plans of the others, this individual might lack both the model and the necessary skills for negotiating conflict. So if the lady has perceived that her mother has always been submissive, she has always given in to the desires and actions of her father, she will have difficulty communicating this to her partner, no, that I need help from you. I need support from you. Because in her, the primary schema is that this is my responsibility. So if I am not able to do it, it is my responsibility and the guilt must turn. Because she has never seen her mother taking an active role. So the background factors, how it has contributed and shaped their understanding of their respective is something we need to visit in the initial phase. This point is clear because this is a very important aspect. Should I move on? In continuation with exploring relationship models, not only their parents' role, also the quality of attachment also needs to be understood. Developing understanding of the quality of attachment that each member has developed with their respective parents. Because understanding this attachment style will, with regard, in the context of their early caretakers and their experiences and the kind of attachment that they have developed with their parents, will have a transition when they become a parent and they need to take care of the child. So if a mother perceives or one of the partners has perceived that I was not given adequate attention, I was not valued adequately, I was not, my parents were not available for me, then somehow subconsciously that individual may be overly occupied with the child. So there might be a tendency of being overly anchored to the child or being overly protective towards the child, and that might lead to a development of a nagging behavior, finicky behavior, always being restless when the child is not around, or maybe the child is with the other partner. So these behavioral changes can also be there. So because the attachment that the insecure attachment that she has developed with regard to her bringing up period and the way she connects to her parents is subconsciously, she might not be aware, is getting reflected in how she is going to take care of her child. So this attachment pattern is also very important to be elicited of each partner attachment style with their respective parents, because that will have a reflection on how they are going to deal with their own child. Clear? Now, history of the relationship. So when we are talking about history of the relationship, it's the couple's relationship. Now we are coming to the present scenario. How both the couples over a period of time has evolved as couples. What do they understand about each other? How did they develop a bond? How did they reach to a conflict negotiation point earlier, and how things deteriorated over a period of time? So that longitudinal understanding of the couple's relationship is also very important, because then that pattern needs to be implicated when actual resolvement has to be done. Couples' joint construction of the relationship serves to unify the couple as they hear one another express how they hold one another in mind. What is my perception of my partner, my views about my partner, and my partner's view about myself. So when in the conjoined session, I'm expressing my thoughts about my partner also gets to know what is my thought process about my partner. So that sets the premise for further action. By reminding them of ways they have solved problems in the past. Now, this is the role of the therapist. When we try to understand what kind of conflicts you people have engaged in the past, how did you resolve it, who takes the initiative, how long does it prolong, or you people are able to talk about it and resolve it. All these pertinent questions have to be addressed. And it also gives an opportunity for each member to learn about their partner's point of view, and it encourages them to engage cooperatively. Early stages of the couple's relationship, definitely the component of attraction is there. How, as I said earlier, what were the problematic areas and how they worked together to resolve it. And then gradually the therapist will bring in the point of discord in the present context. Got it? So a gradient has to be built. how consolidated their relationship was, number one. Then how they used to resolve conflicts whichever have arisen over a period of time, and then coming to the present context. So mostly if we talk about the relationship dispute centers about what areas? Household responsibilities, finances, decision-making pattern, social obligations, work commitments. These are the areas where couple conflict may arise over a period of time, right? Now, all the existing roles that the couples have been playing in their life, how all these have been impacted or aggravated after the delivery of the child. That needs to be understood. During this postpartum period, whatever role and responsibilities that were divided earlier was there, how it has got impacted now. The clinician explores the way in which these areas have been specifically impacted in the postpartum period, because an aim of the conjoined IPT is to develop the clinician tries to sense, but at the same time tries to develop also the readiness to change and readiness to work around these issues, whatever has been the identified issues in the during the therapeutic sessions, by accessing their thoughts on the impact. So unless if I think that earlier my husband used to we had a very democratic approach while taking decisions. Both of us used to sit down, list out the pros and cons, then we used to take a decision. But gradually, after the birth of the child, I'm so engaged with the child, he mostly takes decisions on his own. He has taken decisions that I will not work, or maybe I will take a prolonged leave, or maybe the child will stay with in the certain child care center. And he has taken all these decisions on his own. He has never incorporated me. So this is the way it has impacted. That is the elicitation. Now, what will be the... So if the partner is able to explain that this is the impact, what is happening? It's a conjoined partnership. So the partner is also listening, no? What am I feeling about the whole scenario? That how I was included in the decision-making pattern, but now how I have been avoided. And this perception of the partner that now she has been avoided or now she has not been included is something automatically communicated to the partner. Anyway, okay. So, and from there, the clinician also needs to identify and understand how they together see themselves in the future. They have built a relationship that is a component of past. How the previous pattern of relationship has got impacted during the postpartum period, or then during this difficult period that which they have presented to the therapist. And now the therapist needs to facilitate and develop an understanding, where do they see themselves from here in the future, so that that gradient could be understood, and the gradient is also communicated to the couples, so that they become aware of it. Because once they are aware, then only we can bring them to, that develop that readiness to change. So that needs to be established. By asking the couples about how they foresee for their future, the clinician tries to renew their motivation for improving the quality of life and, quality of their relationship and of the future envisioned for themselves as well as their family. So, why? Because during the conjoined, during the conjoined session, whatever is being expressed by one of the partners, the other partner is automatically getting communicated about. And so that communication means helps the other partner get a dive into the perception of the other partner, that how things have changed, and now things, and what is our common goal as a couple. And if there are certain common goals of our couple, then if we are stuck over here, we need to work together to overcome this obstacle and move further. So there is a renewal of motivation. And then the assignment of dispute list. In this, therapist particularly asks both the partners separately to think and develop a dispute list, their areas of concern, their areas of dispute separately, and not to share with each other till the next session happens. So they will think, they will identify their old dispute areas, but they will keep it private. They will not share it till the next session. Now with this, we come to an end of the first phase of conjoint IPT, where to summarize, we try to gather information on all the various aspects of the relationship and how it has changed or has got impacted during this postpartum period. Clear? Thank you. I think we will continue after the tea break.
Thank you so much, Ashmi ma'am, for such an insightful session. So now we break for tea, and the tea is served in the fryer. So if you may proceed, and after 15 minutes, we will come back and rejoin the session. Thank you.
So we will continue. Starting with the middle phase. Middle phase comprises of approximately 5 to 6 sessions. And this is the session, this is the phase where the actual work of making a difference or making a change takes place. So the clinician asks to see each member's list, the dispute list that has been given at the end of the first session, first phase, and clinician reads the list of the dispute themes that were asked to be completed by each of the partners. And after that, after identifying and staging the key disputes, the clinician tries to make an understanding or tries to frame a perspective that where is the dispute at what level? Is it at a level where from their perspective nothing much can be done and like this is the end, ab kuch nahi ho sakta? Is that's the perspective, or there is a scope of negotiation, or they are already trying to make a difference, they're already trying to address their conflicts, but maybe not that successful, they're not getting the desired results, or they have reached to an extreme position where they are just thinking of disillusioning the relationship. So basically in this phase, initially the clinician tries to gauge first the crux of the problem and the intensity of the primary concerns that they are coming, so that from which level the clinician needs to start or motivate the partners to work toward the change. So based on this information, the clinician collaborates with the couples to develop a plan of action so that they can renegotiate the disputes. The techniques generally used are use of affect, communication analysis. We are all acquainted with this term since yesterday we are listening. Role playing, decision analysis, psychoeducation, working towards change between sessions. Use of affect is release of the emotions. So when both the partners start communicating their thought process about the dispute, their emotion, the other partner automatically gets acquainted with it. So encouraging the affective expression of a member that may lead his or her partner to shift the change behavior accordingly. So there is a change. Obviously, the therapist will play the role of a facilitator, but when I start complaining that the way I'm not feeling supported, I feel overworked, I don't feel that anybody is listening to me. So when I'm expressing myself, there is an emotional release, and at the same time, my partner is also getting acquainted with the thought process that I am going through. Distressed couples frequently engage in a cycle of attack and defense. So the partner may start saying, नहीं मैं तो सब कुछ करता हूँ, इसको कुछ समझ में नहीं आता है, ये तो हमेशा रोती ही रहती है, सिर्फ अपनी बातें बोलती रहती है, ये और किसी चीज को वैल्यू ही नहीं देती है. So the other partner might take a attacking stance, or they may take a defensive stance. That no, whatever I'm trying to do, in my own way, I'm trying to help her. Now, this attack or defensive stance actually takes us back from renegotiation, because over there, the empathy is not there. They are just minimizing each other's pain. They're not validating their distress. They're not validating each other's viewpoint. So, and over there, the therapist is able to understand with this interaction that the first problem is not valuing others' perspective or others' emotion, and that needs to be addressed. So helping couples to express their emotions, listen to their partner's feelings, helps to break this cycle. So that's the reason initially we talked about that the therapist needs to work as an ally, and there will be an open communication. So this is where the role plays in. Where when we are sharing their distress, both the partners are expressing their distress, the other partner listens to it, and then the therapist observes what kind of a reaction the other partner is bringing in, whether it is an attack, whether it is a defense, whether it is non-acknowledgement of the other partner's distress, and then navigating it further for expressing the emotions, breaking this cycle of negativity, and establishing a more satisfying way of relating to one another. That will be taken further in communication and decision analysis. What happens in communication analysis? So when there is a problem, of course, over a period of time, the couples have interacted and they have established a pattern of communication, right? So to understand what has been the established pattern of communication, the therapist usually asks of a detailed discussion or detailed understanding of the past conflict or argument that has taken place and how it transpired between the couples, and linking it further, what is the current conflict, and with regard to the current conflict, how the individual is talking to each other. Clinicians monitors and labels faulty communication patterns. So if they are not acknowledging, they are getting angry, they are dismissive about the other partner's feelings and emotions, these faulty patterns, this is the role of the therapist, that he identifies and communicates it to the respective partners. So once the labeling of the faulty communication pattern has been done, then how to renegotiate and how to engage into a better communication pattern, the process will start. Labels faulty communication patterns, link them with unsatisfactory outcomes and worsening of symptoms or relational discord. So it's not just about faulty communication patterns, but how it is indirectly impacting to the intensity of the concern that the depressed individual is feeling, and also how it is contributing to the deterioration of the relationship. So now, subsequently, the therapist's role comes in, where he coaches the individuals for better communication pattern, either through the use of role play, or during the sessions also, whatever conflicts they have bring in, that incidents can be used as a context of role play for better communication establishment, and also the assignment of practicing the similar kind of communication pattern back at home, that it needs to be generalized back to their normal life. It needs to be integrated in their normal regular life. So role playing and practicing of more effective communication sessions further helps to solidify the communication pattern. So first, what will happen? The therapist will take a detailed description of a recent past argument, how they communicate each other. The therapist may make the couples do a role play because the context is already set. The argument is already a thing of the past, but how they have behaved at that point of time will set the pretext of what personality characteristics they bring in, how do they react, how do they express themselves when there is a conflict, and then from there he brings them to the current conflict. From there, he shares the feedback of what kind of a communication pattern exists between the couples, and then what adaptive communication patterns needs to be imbibed there, inculcated. Clear? Decision analysis. Decision analysis is action oriented. What needs to be done if there is any decision or perspective that is on hold and they are not able to reach to a final call about what needs to be done, that has also can be addressed and decision analysis can be utilized. Helping the couples to consider various avenues and possible consequences. Now, suppose it generally happens, right, that a lady who has undergone postpartum depression, already there is a transition, then maybe she has been a working lady and she has taken leave during her delivery and everything. And now she is looking forward to the idea that once my leaves are over and I'm settled down, I'll make arrangement of how my child will be taken care of, and then gradually I will report back to my work. The husband's perspective might be, and they're not communicating to each other, maybe at that point of time, that it's done now, we have a family, we have a child, we are living in this big city, there is no support system, so maybe leave the job. That might be the perspective. Or vice versa also, there may be a perspective that he's now asking her to join back. And she's not able to figure out how to take care of the responsibility and move ahead. And then, so reaching to a decision. So this example of she joining back, maybe she's not willing to work. So the myriad kind of concerns may be there. She might be willing to work and we might not be ready to ask her to go back to work, number one. Or there might be a situation where she doesn't want to go to work, but he is insisting because he has some other botherations. So now if this is a concern, what kind of a decision analysis can be done over there? Maybe the options that can be discussed upon is maybe she will join a little late, maybe another 6 months she can take a leave. Maybe she can opt for a flexible option. Maybe she will talk to the authorities and reduce the duration of work. So, but in a heat of the emotion, then it seems very simple. But when two individuals who are not communicating, who have a faulty communication, they are just reacting to each other's point of view, not settling down and listening with regard to the concerns, they're just imposing their views, right? At this point of time, this kind of communication analysis as well as decision analysis comes handy. But once it has been identified what is the primary crux of their dispute and what all decisions, multiple options can be taken. So decision analysis is basically, to some extent, a problem-solving approach that needs to be followed. And so that both of them can come to the same point. And along with this works perspective, the female might have a feeling that I do not get adequate kind of support. Simple things, changing the diaper of the child, making the child take a bath, feeding him, because each and every activity takes its own set of time. So even receiving a little bit of help from the family members or from the partner might be helpful. But at times they might not be able to communicate these things. So as a part of the decision analysis, it's not just about there is one particular difficulty and you reach to a decision. So many other myriad layers also needs to be addressed. and within that, how and when the partner can pitch in some help will also act as a sense of relief, and the trust building of the sense of cohesiveness is the output of this interaction that takes place. So as we proceed further, what happens is, since it is an action-oriented scenario, and it encourages the couples to work on the issues between sessions. So early assignment is about improving the communication skills. Then assigning exercises that equally engage both the members of the couple and generate measurable, achievable tasks to foster a sense of competence and accomplishment. So measurable and achievable means doing those objective particular behaviors within the regular life that will contribute to the well-being of both the partners and enhance the relationship quotient. So that's the reason this measurable and achievable perspective is mentioned. The postpartum context is to be taken into consideration while assigning exercises. For example, decision analysis may be incorporated to address issues related to childcare if the couple decides to spend more time together with the baby. Now, that can also be an issue. You're not able to spend time together. So these small things needs to be addressed. So how when they wish to, they can identify that within a week at this particular time, maybe we will figure out a time to spend time together. And that point of time, what are the options where we can keep the baby? Can we keep the child in the childcare or with some relatives for some time? Maybe we can have an outing, and then again, when we are rejuvenated, we can come back and take on our responsibilities. So these smaller decisions of life also, they are not able to, at times the couples are not able to take when there is a discord within them, or they are not able to express themselves adequately. The final phase comprises of basically 2 sessions. So over here, the therapist primarily consolidates and summarizes the achievements that has taken place in the entire 7-8 sessions that has taken place, number 1, and also emphasizing that different modes of communication that you have established or that you have learned, how you need to continue with that, and how it's like validating the change that has taken place, how they are engaged into more healthy relationship, communication, how they are more empathetic towards each other, how they are able to negotiate with each other when there is a conflict in the relationship, or how they are overall responsive together in a situation and are ready to adjust with each other. So who is the person who can validate? Therapist is the person in the sessions, because he is the neutral lens who is able to see both of them and their progression of change. So if the validation comes from there, then it gives a message to the couples, now that we are ready and we are equipped with the required skills, and so that we can continue with our regular life from this approach. The therapist also emphasizes that it is the couple who has been the responsible for change. He or she has just facilitated. So once again, validating that you have the capacity to bring that change. It's just that you need to acknowledge it. So once again, validating the sense of competency and facilitating autonomy, that it's not that this therapeutic session is going to continue for lifelong. These are the few skills that you require. Now you are all set to go. Another objective is to identify any ongoing issues. So now, since we all know this is a time-limited therapy, the interpersonal in the interpersonal arena, whatever disputes has been identified, it has been resolved. But life is not stagnant; it is going to continue. So there will be other issues that will come up, or still maybe there are few issues that is not going to be addressed within the scope of this therapy. But now you have the required skills; you can work on it. Therapy sessions provides couples with a chance to discuss their problems on a regular basis in a continued and constructive way. The clinician encourages the couples to protect a regularly scheduled time to deal with ongoing issues or simply to connect with one another. That you both are equipped to work and solve the concerns. The identification of potential obstacles can help the couple recognize triggers and develop a concrete plan for ways to approach future problems. The clinician reassures that stress is a normal part of life or of any relationship and difficulties are to be expected, but now we're equipped to handle it. So with this, all the three phases of conjoint IPT comes to an end. We'll have a brief discussion around a similar case presentation. So this lady, who's 38-year-old lady, presented with perinatal onset of major depressive disorder, with symptoms of depressed mood, irritability, helplessness. The symptoms started 4 weeks following her delivery and persisted for 6 weeks prior to the point when she presented herself for the consultation. She scored a value that indicated moderate level of depression, and she described depressive ruminations and fatigue from juggling multiple roles as wife, mother, daughter-in-law, etc. And she was afraid to talk to her family about her stressors for fear of over-involvement. However, there was no suicidal ideation. Prior to her marriage, she was working as a medical officer in the medical department. She gave up the clinical work 5 years ago to do administrative work. That means she already, there was a shift in her work profile before becoming a mother. Because the nature of her work required night shift availability and her husband and in-laws did not approve of the night shift. However, she was bored with the mundane administrative work, and while her husband was advancing in his career, she felt left behind. She was also feeling guilty for wanting to pursue the career of her choice, that is the clinical work, and to think that her children were the reason for her feeling too dissatisfied with life, compounding her guilty ruminations. She was thinking of returning to clinical work for some time, however, was fearful to make the change, and she also was finding it difficult to communicate her desire and emotions with regard to her job, shifting her job from administrative to clinical to her husband, fearing that he might not understand or support her. So now, given if this is the pretext with which the client presents herself, as we discussed in the initial phase, the clinician needs to gather some kind of information, right? So what all steps needs to be done? We just covered now, so maybe you can take a reference and share. I'm just talking about the assessment part, what all you need to do. Anybody? Any? Just try. Ma'am, I know you can do it. बताओ बच्चों, मैं काफी लोगों का नाम जानती हूँ. Just give it a try. What was the first step that we discussed? When we are including both the couples for therapy, what was the first step that we discussed we need to do? The psychoeducation. Wonderful. Then exploration of role model. Very good. Role model in the context of? Good. And before that, understanding of their social support. So let me summarize. So initially we started with psychoeducation, then exploration of their social support, right, of each individual partners. Then understanding of their role model during their growing up periods and their attachment style. Then linking their present relationship distress to the condition that the partners are undergoing. Then काफी तो मैंने बता दिया, आगे बढ़ो. History of their couple's relationship. Yeah, right. So how they have been managing disputes and reaching to a conclusion, and how they have been navigating their difficulties. And then coming to the present context, what they need to do? Dispute list. So this all is relevant over here with this case. Towards the end of the initial phase, and that is the premise for the middle phase. Initial phase, yeah. When the therapist equips himself or herself with all the relevant informations. Okay, so what all can be done? The assessment part is over. Okay, and we know that the middle phase is the phase that wherein the change takes place. So, what all can be done with this couple? Try to identify the areas, the goals. Very good.
So that domain of deficits in interpersonal communication with the husband, right? And then
the desire to
also get back to work. That is one core.
Wonderful, wonderful. Anyone else?
Detailed descriptions of past arguments.
That is a part of which analysis? Communication analysis. Okay. So see this is visible enough. So the goals over here are to improve communication with husband and transition back to work. So you were able to identify the goals. Good for us. So we are all set. Okay. So what is the expected mechanism of change when we are talking about IPT in the conjoint form? Is in a nutshell is definitely one angle is to increase the partner support, parallelly decreasing the anxiety and aloneness that the individual with postpartum depression is experiencing, and parallelly also reducing the sense of anxiety and aloneness in the partner as well, and at the same time reducing the depressive symptoms. This in a nutshell is the 3 key points that we need to keep in mind, and this is the mechanism of change. So if there is an increase, there will be a reduction in depressive symptomatology, there will be an enhancement of relationship, and further the spiral will work accordingly. Now, when we talk about IPT in conjoint form, there are certain strengths and limitations as well. Strength as a therapy, it has a strong empirical foundation, especially for mood disorders, and it focuses on the emotions. So it helps the partners to connect better at an emotional level and be oriented to each other's internal experiences. That is very important. Time limited, so it encourages to target upon the concerns and work towards the progress. So you do not, it's not that it is going to go on for a prolonged period of time. And definitely it is collaborative, and that inculcates the sense of mutual responsibility and growth in the relationship. Talking about this, the limitations of this approach, that there are many kind of interpersonal equations which is highly abusive in nature and highly such as cases of domestic violence, There are one or two articles where they have tried to inculcate IPT approach in dealing with these cases, but the evidences are still very limited. And definitely intergenerational concepts are not addressed over here, though we try to understand how they connected with their role models, but beyond that, we are not addressing the intergenerational issues. It is just restricted to the couple's disputes and concerns. And during the process, if the therapists tend to understand that there is a long term, either of the or both of the individuals have personality concerns, though IPT is one of the evidences, but the extent, the intensity, and other difficulties associated with the personality of the individual, because of which a particular role dispute is not being able to be handled, maybe they can be addressed separately and then can be prepared for the conjoined part. With this, we come to an end. Just to summarize, adapting interpersonal therapy for couples problem provides a practically emotionally attuned and goal-oriented framework for addressing relational distress. It emphasizes on interpersonal dynamics, emotional expression, and role transitions, aligns well with the common challenges that brings couple into therapy. While not a universal solution to all couple difficulties, IP offers a structured and effective method particularly suited for couples dealing with mood disorders, life transitions, and communication breakdowns. Thank you. Any questions? Anything that people would like to ask? Or we may begin with the next session. We already delayed maybe by half an hour, right?
Use of IPT in couples therapy? Do we have, because I'm also considering the systemic lens and the cultural context. So how, in practice, how does it come out?
See, with regard to researches that I have gone through in the past, few things while I was preparing also for the same. Initially, the first few researches were done somewhere in 1970s and 80s. And thereafter, in the recent scenarios, few studies from China and Hong Kong has come there, particularly pertaining to postpartum depression, or perinatal depression, where they have incorporated, they have conceptualized it as partner-assisted IPT therapy or conjoint IPT therapy for first-time parents. So the recent times from maybe 2022 onwards, few researchers have come across. I have got descriptive papers of IPT in the Indian context, but to my limited understanding, I have not come across any paper implying IPT in conjoint format in the Indian scenario. So we're still in the budding phase.
Thank you.
Ma'am, I had a question. Can IPT be used in cases where the partner is cheating?
Yes.
Infidelity?
Yeah.
Can?
It can be.
Okay. Ma'am, can you help me understand how?
I will share a paper with regard to that. I have a paper. It has given a detailed understanding of the same.
Thank you, ma'am.
So I'll be able to help you with
Yes,
that.
thank you, ma'am.
Thank you.
The evaluation sheets have been circulated in the WhatsApp group. Kindly fill the evaluation sheets for the first 2 sessions of the day. Right, I can see some participants have already done this, so we'll move forward. Moving forward for the day, it is my privilege to welcome our distinguished guest speaker, Dr. Prasanta Kumar Roy, sir, Head of the Department of Clinical Psychology at Institute of Psychiatry, Center of Excellence, Kolkata. Sir will be telling us about all the nuances of IPT we have covered in basic sense, but sir will take us towards more detailed, advanced application in personality disorders, as well as research and other ethical considerations that we need to keep in mind while practicing IPT. I welcome sir. A big round of applause for sir, please.
Good afternoon. Thank you for giving me the opportunity to be part of this CRE. And I'm happy to see that the kind of responses the mental health professionals and the future mental health professionals have shown about the understanding of interpersonal therapy. And I'm sure yesterday you had a detailed understanding of interpersonal psychotherapy. Today, whatever I heard from Rasmi Madam uh, and the ways he has covered interpersonal therapy, conjoined mode, as if she herself has done with the clients, and it was such a lucid presentation. But my presentation is not going to be that lucid. Because dealing with personality disorder itself is bumpy. And it is having lots of impact on our emotion too. Lots of transference, counter transference issue that might comes in. And all this can have some impact. And moreover, when you discuss about IPT for personality disorders, though research is positive about it, at the same time, IPT we might not consider for personality disorder as first line treatment. That you need to remember. Because the development of IPT was only for some acute crisis that is having its impact on the emotion in terms of depression. And that was the basic concept. Later on, because of its anchoring with the interpersonal connectedness and social support system, It has been found to be effective for many other conditions, like case study you had discussion about anxiety disorders, depressive disorders, condition like grief as well as complicated grief, conditions like psychological trauma or PTSD that is not discussed, and also in bipolar disorders, particularly bipolar depression, and chronic mental health conditions like dysthymia. And initially, when IPT was conceptualized, it excluded those cases with suicidality. And it was found to be more effective for mild to moderate depression and severe depression without suicidality. However, now the protocol is there that shows its efficacy to deal with suicidal cases using IPT, because most of the suicide get triggered by the interpersonal factors or issues. And because of the connection between eating pattern and interpersonal factors, so now on eating disorder also interpersonal therapy has been found to be useful. Now, if you look at these many conditions, be it eating disorders, be it complicated grief, be it psychological trauma, dysthymia, in many of these conditions, we'll find they are also having personality disorder or some personality trait as a core. And it is not uncommon. Even you look at body dysmorphic disorders, they are also the personality hypochondriasis, the personality disorders or personality pathology are part of the core. So whenever they started dealing with those cases, it was really impossible to exclude the personality disorder. And they had to focus on personality disorders. And they found that with some of the personality disorders, the model can be effective because the way it conceptualizes depression and the similar conceptualization can be observed in borderline personality disorder. The way they conceptualize anxiety disorders, particularly social anxiety disorders, IPT has been quite effective. In the similar way, it can be conceptualized as in avoidant personality disorder. The mechanism is almost similar. So, but at the same time, if you look at some of the axis 1 conditions, though it was initially prepared for axis 1 disorder, till date we do not have any protocol for obsessive compulsive disorders based on IPT, because it is difficult to conceptualize OCD with respect to the obsessive compulsive disorder. It doesn't mean that patients with obsessive compulsive disorder do not have interpersonal issues, but we do not have any model on that. Maybe there are better treatment options, and we know that without focusing on the exposure task, dealing with OCD might be difficult. So there was no need to focus on the interpersonal therapy, but interpersonal counseling. Interpersonal counseling is a low intensity therapy that can be practiced by anybody who is having basic understanding and training on interpersonal counseling. And this interpersonal counseling can be incorporated in various other treatment conditions where interpersonal modality is not the first target of the treatment. And you already know about the basic tools of interpersonal therapy, some of the basic concepts, encouragement of affect, communication analysis, decision analysis, interpersonal inventory. So these are the basic issues. And actually, if you practice interpersonal psychotherapy, it is one of the easiest psychotherapy. सुनने में बहुत लगता है इतना कुछ करना होता, but this is one of the easiest psychotherapy, much easier than CBT, cognitive behavior therapy, because cognitive behavior therapy is much more technical. And if you look at Indian context, as the focus is on the emotion of the individual, the people can readily identify with this mode of therapy and it is easy to follow and continue. So, you had discussion about the theoretical foundation of interpersonal psychotherapy, but I would like to repeat some point of it because it might be related to the understanding of the personality disorders. And whenever you look at personality disorders, we try to understand from evolutionary perspective. And it is particularly true for borderline personality disorders. It is particularly true for narcissistic personality disorders, where the kind of emotionality and the behavioral pattern, those are most defensive behavioral pattern. And it is understood that it might have evolutionary connection. It's kind of a survival mechanism for them to reduce the arousal. Sometimes they are able to reduce, sometimes they are unable to reduce. But from the theoretical aspect, we focus on the biopsychosocial model that you all know about interpersonal therapy. In the biological model, you know that it is caused by the combination of biological vulnerability and the psychological vulnerability as well as the social or cultural factors. Someone was asking about the cultural aspect. So here we do consider the, under the social stressor, we do consider the cultural stressor also. So what are the interpersonal consequences of any biological symptom? For example, one biological symptom is difficulty in getting sleep. What would be the interpersonal consequences of that? What would be the interpersonal consequence? What would be? But interpersonal consequence. Yeah, I might be irritated. So my communication with someone might be disturbed and that can have impact on the relationship. Or might be because of the sleep deprivation, my attention span is low. So what the other person is telling, I'm unable to process that properly and that can create a conflict. If I'm feeling more tired, what is the interpersonal consequence? No readiness. मेरी वाइफ के साथ आज घूमने जाने का प्लान था, बट आई एम फीलिंग सो टायर्ड, आज नहीं जाते, बहुत थकान लग रहा है. एंड क्या होने वाला है? Either disappointment to the others or some conflict. Okay. What is the interpersonal consequences of increased heartbeat? What is the interpersonal consequences of increased heartbeat? Interpersonal consequences. I will be more preoccupied with the heartbeat. So my reciprocation would be minimum. Okay, so each of the biological symptoms will have its interpersonal consequences, and IPT is this therapy where we try to focus on how much each and every symptoms are having some interpersonal consequences, and how psychological factors impact relationship. For example, psychological factors like cognitive distortion. If there is a jumping to conclusion, 12 baj gaya. Okay. If there is low self-esteem, what will happen? There will be more distancing from the relationship if there is low self-esteem. If there is poor emotional regulation, there can be more conflict in the relationship. And if there are maladaptive coping strategies, like avoidance is a maladaptive coping strategy, what can happen? Obviously, the interaction will not be there and my relationship will not be built. How social or interpersonal factor or cultural factor impact the biological and psychological symptom? How? Yeah, like loss of a loved one. What kind of the biological and psychological symptoms? Sleeplessness, sadness, depression. So we know about this issue. Now, these interpersonal factors as the area where change can most effectively happen in therapy. And that is the importance of interpersonal therapy that we know. So, if you can modify these interpersonal factors, we will be able to modify the biological factors, including temperamental vulnerability. Temperamental vulnerability is also a biological factor. Now, if you consider the personality disorder, there are certain temperamental vulnerability in them. For example, in borderline personality disorder, emotional dysregulation is a kind of a vulnerability. Impulsion is a kind of a vulnerability. So, if the interpersonal area is being protected, what will happen? It will reduce the arousal to reduce the emotional dysregulation vulnerability of an individual. So, treatment acknowledges biological issues, but the therapeutic work is social and relational. It acknowledges the biological issues, and that's why IPT also acknowledges the role of pharmacological intervention. And even for personality disorders, they have whatever the researches are there. In most of the researches, they have conducted IPT along with pharmacological intervention, even in personality disorders. And the proposer of the interpersonal psychotherapy, they believe in all the conditions. The best outcome can be obtained, though it is comparable with CBT and antidepressant medicine for the management of anxiety and depression. However, the best outcome can be there when the combination of the treatment is available. Combined treatment is available. That means pharmacotherapy as well as interpersonal therapy. And it acknowledges biological issues in terms of the disease model. It gives a sick role so that the person feel unburdened. Me and my depression is separate. Me, my personality disorder is separate. So it is the sickness. And because of this, and that is the medical problem. And because of this medical problem, you are suffering. Because of this medical problem, probably you had discussion about how we do formulate in interpersonal psychotherapy. And second is attachment theory, particularly the Bowlby's attachment theory. And it says that early bonds with caregivers shape our expectations in later relationship. Now, if you look at IPT, it is here and now. Though in personality disorders, we will be focusing more on here and now, but we will not be able to exclude the past attachment. The madam was telling about the role models. Okay. And Bowlby has mentioned about secured and insecure attachment, because those are responsible to build trust in the relationship, to feel protected, feel secure. So secure versus insecure attachment style influence emotional regulation, trust, intimacy, and communications. And now if you think about any personality disorders, these issues are disturbed, be it communication, be it intimacy, be it trust, be it emotional regulation at various degree. For example, in paranoid personality disorder, the trust issue is mostly disturbed. Emotional regulation is very much disturbed in borderline personality disorder and histrionic personality disorder. Whereas emotion sometimes is highly regulated in obsessive compulsive personality disorder. Okay. And psychopathology often follows disruption in the attachment. And therapeutic relationship is being created as a secure base. Now the person who doesn't have access to problem, only coming with access one problem, we assume that he or she is already having the secured base. Obviously, the kind of the therapeutic alliance will come to that in more detail, but the kind of therapeutic alliance that particular person without any access to vulnerability will form, it is not going to be the same for the axis one. And here the therapist's job is to create and recreate that secure base within the therapeutic alliance, so that that learning can be taken outside the therapy room. And then comes the communication theory also. It says that most interpersonal problems stem from miscommunications, unclear expectations, or poor expression of feelings. Miscommunication, unclear expectations, or poor expression of feelings. And psychopathology are maintained or worsened by dysfunctional communication pattern in relationship. And communication can be both problem and solution. And psychodynamic understanding, unconscious emotion often emerge in close relationship, though we are not going to interpret that, but it is evident even in interpersonal therapy. Recurring interpersonal patterns that may have historical root, we call it the interpersonal schema and interpersonal cycle. Our sense of self is shaped through the relationship. And in most of the personality disorder, you will find the sense of self is fragile, disturbed. Ego identity is ruptured. Emotions are seen as central to understanding and navigating relationship. Encouraging the clients to identify, express, and make meaning of emotions in the relationship can be helpful. Now, if you look at the symptom development model of interpersonal psychotherapy, whatever we were discussing, did you discuss this yesterday? This model? Okay, I'm not going to them later. It is the same thing. Yeah, whatever we were discussing, here the two things are important. One is contextual factor, and second is the current interpersonal problem. That is already being discussed. And there is a third factor also, the kind of social support that the individual is having. Now, if you look at personality disorder psychopathology in more detail, all PDs are complex pathologies that we know, and contributed to by various aspects, whether temperamental, learned, or developmental. and dysfunction in relationship and in the capacity to understand mental states. They are not in a state, they are having problem in their metacognition. It includes difficulties in undertaking independent actions, regulating affects, and consciously managing subjective suffering in all types of personality disorder. PTs are having impoverished or intellectualizing narrative style. We all of us depend on our autobiographical memory. All of us are having some autobiographical memory. So, people who are not having personality disorder, they will be able to give the detail of some of the experiences, autobiographical experience, in terms of spatial, where it was, in terms of time boundary, when it was, and who had been the actors, that means who, and what kind of acting was going on, what kind of conversation was going on, and why this was going on. So these are the complete details, and we will be able to provide some documentation on those experiences, and those are part of the autobiographical memory. Autobiographical memory may not be a conscious memory. But in most of the personality disorders, they will not be able to give it. If we talk to a person who is having borderline personality disorder, and if he or she narrates a particular experience of past, they will not be able to give the details of what, where, when, why, who, the details of it. They might be able to give some fragmented in a overgeneralized way. As a result, whenever you are listening to this, whatever the verbatim or the narratives they are giving, it will appear as if there are many people who have done so with this particular individual. It was not person specific. So it is their impoverished narrative style. And to compensate that, what they do, they use lot of intellectualizing processes. Like, शायद मेरा जिंदगी ऐसे ही चलने वाला होगा, जिंदगी शायद ऐसा ही होता है सबके लिए. More of a philosophical kind of generalized response pattern they might give, and these are intellectualizing the narrative style. And you will find with obsessive compulsive personality disorder, anxious avoidant personality disorder, borderline personality disorder. And they are having problem with their meta memory. They are having limited or fluctuating sense of agency. What is agency? What do you mean by agency? It's a kind of subjective self-awareness. Agency is a kind of subjective self-awareness about wishes, kind of desire, kind of wishes they are having. I want to be loved. I want to achieve. I want to be famous. I want recognition. I want to be secured. I want to be calm. So these are the wishes. And inclination and the goals. So it is thus a subjective self-awareness about the wishes the kind of inclination the individual is having, and the kind of goal is having. And also the ability to execute behavior in a way so that those wishes, those inclinations and goals can be reached. So that is that is considered as agency. And in most of the personality disorder, we will find that they are having limited agencies. And sometimes the agency might be, it appears like it is high. For example, in narcissistic personality disorder, it might appear that they are focused on a goal and they are running for that. So it might appear that the agency is on the higher side, but they are on the fluctuating state. They are not constant. So this is another issue that we'll find with most of the personality disorder. Third, they are having pathognomic interpersonal schemas. Interpersonal schemas, I'll explain. If we look at this model, the interpersonal schema structure, we're mentioning about wish, and we are having some wishes. I want to be loved, and based on wishes, I'm having a kind of a self-image that I'm lovable. That is the self-image. And based on the self-image, what kind of self-reaction to others' response will happen? There can be two kinds of reactions. I went to someone and the person didn't look at me. So that is the other's reaction. And from there, what kind of reaction I can have? I might start avoiding that particular person. And because I started avoiding that particular person, the other person became critical about me, the other's response. And that particular person who became critical of me, from there is an assumption in terms of if then. In terms of if then, if I reach to people, if I can please someone, then only people will take care of me. And from there, my wishes would be different. What happens particularly in personality disorder, the cycle is completely reverse. It begins with wish and then it goes to the if-then procedure. And from based on the if-then, we look at the other's response. And based on the other's response, they manifest their own reaction. And because of the manifestation of the reaction, they form self-image. Unlovable, abandoned, this kind of self-image they can have. So this is a kind of interpersonal schema they form. For example, that I'm unlovable, that is a kind of interpersonal schema. Now, if you look at these three issues, impoverish the narrative style. So there also, it is not without any interpersonal interaction. Limited sense of agency, obviously it will have a lot of interpersonal impact. And these interpersonal schemas, when they are dysfunctional, they are negative, obviously it will have its reaction into the interpersonal communication. And there are interpersonal, dysfunctional interpersonal cycle, and that is based on the diagram that I showed. Now, because I have formed a self-image of interpersonal schema that I am unlovable, and what would be my interaction pattern then? Either I'll start criticizing people or I'll start avoiding people. What will happen? And this will validate. So it will create a loop for me, a vicious cycle for me to re-experience the same schema again and again. So that is the dysfunctional interpersonal cycle. And there are recurring mental states in the individual. Recurring mental states can be of two types. One is the feared or distressed state. The fear or the distressed state. And the second is the coping state. The person with this schema, unlovable schema, the person's emotional reaction will be distressed whenever he is in present with someone. In the interpersonal circle, if there are some people whom he considers within the close circle, in presence of them, the individual will have more activation of this schema that I am unlovable. So there will be a fear of rejection. So that is the feared state. The fear of disappointment, fear of abandonment. So that is one kind of mental state. And this is recurring mental state. And the second is the coping. Coping means my behavioral pattern. Avoidance, withdrawal, procrastinating. So these are the coping pattern that individual forms or develop to help him to survive. And that is also a recurring pattern that individual follows. And sometimes this coping pattern, not all the time, sometimes this coping pattern might be egocentric. The person might not feel that this is a problem. For example, in anxious avoidant personality disorder, if there is a fear of rejection, that particular person, what the particular person will do? The particular person might be bothering the partner, particularly in dependent personality disorder, for example. So I fear of, because of the fear of loneliness, I might be bothering too much my partner so that she stays with me. At the same time, another person with narcissistic personality disorder, he might be bothering the partner to get fun, to showcase this man identity. For this narcissistic person, this can be an egocentric approach. But for the dependent personality disorder, this is not an egocentric approach. That is a kind of a coping approach. Okay. Is it clear, this point? So these are the recurring mental state they experience, and there are metacognitive dysfunctions. Metacognitive dysfunction, metacognitions are the awareness. Again, awareness of my emotions, awareness of the others' emotions, and not only awareness of my emotion, the self-reflection is also there. Whenever I am experiencing a particular emotion, what kind of inclination that I feel, what kind of behavioral pattern are there, what kind of things I feel like doing. So awareness of these reflections are also part of metacognition. So this metacognitive approach is somehow similar to the theory of mind. But theory of mind generally we elicit in an experimental setup. In day-to-day life, whatever we witness, that is the metacognition of the individual. So they are having their metacognitive issues that is activated with this interpersonal schema. And once the person is not that much aware about his or her emotion and how individual is reacting to those emotions, and as well as the understanding of the other's emotion, obviously it will have lot of interpersonal difficulties in the individual. And there are maladaptive form of coping and cognitive biases. Cognitive biases, all of you know, overgeneralization, catastrophizing, and jumping to conclusion, should and must, selective abstraction, personalization. These are the cognitive biases. And because of these metacognitive dysfunctions, they form those cognitive biases. And they are also having problem regulating affects. Some of them, they show lots of affect, and some of them they go for excessive controlling of affect. Even in borderline personality disorders, sometimes they will show lots of affect, sometimes they will inhibit their emotion. They go into the freeze state sometimes. So, in all these factors, you will find the interpersonal domain is important. Now, if you look at the assumptions of interpersonal therapy that is applied to personality disorders, here interpersonal functioning is central to both the development and maintenance of the personality disorder symptoms. And personality disorder manifests through rigid maladaptive interpersonal pattern that disrupt relationship and reinforce emotional distress. Improving interpersonal functioning can reduce symptom severity and enhance overall functioning. And that is true for all the psychiatric conditions. Now, if you look at the mechanism of change, so interpersonal therapy can provide a opportunity for new social learning through examination of the proximal reciprocal influences unfolding within the therapeutic relationship. So that's why the therapeutic alliance with the therapist is of most important. And because of this high importance of this therapeutic alliance, as Rashmi Madam was mentioning about the limited number of sessions, 12 to 16 sessions, the brief interpersonal therapy is of 8 sessions. But within those 16 sessions, we will not be able to deal with the interpersonal issues because it will take lots of time to work on this new social learning through collaboration and building of the alliance. So for personality disorders, it might take 16 to 18 sessions only to form the alliance. 16 to 18 sessions only to form the alliance. Linking identified interpersonal patterns with current symptoms and functional impairment, it is same like other conditions. Exploring the origins and function of maladaptive interpersonal pattern in the client's developmental history. So we need to focus on the attachment as well as the role models. And promotes new interpersonal awareness and learning, resulting in improved relational capacity and symptom reduction. This relational capacity, whenever we talk about, it can be intrapersonal as well as interpersonal. Interpersonal means my awareness of my cognition, awareness of my emotion, and how I am relating to those. That is interpersonal. And interpersonal, that means how I am communicating with the other individuals. In the process of therapy, the attempt to work in the client's best interest and promote a positive therapeutic alliance typically adopts a warm and moderately dominant interpersonal position. Typically adopts a warm and moderately dominant interpersonal position. It is unlike CBT. In interpersonal therapy, the therapist is more active and sometimes to some extent takes a authoritarian stand to suggest something. In personality disorder, there is a positive complementarity. This particular stand doesn't work. In rest of the other psychiatric condition, like all the axis 1 condition, this positive complementarity is helpful. So there is a friendly dominance. Friendly dominance means whenever telling you are having depressive disorder because you are having this symptom, and the client is ready to accept that. There is a readiness in the client to understand it. And the kind of metacognitive process is already available in the client. in the axis 1 conditions, and this particular friendly dominance of the therapy is being well accepted. And it is particularly important in our Indian culture. Now we talk about this Guru Chola issue. So particularly important. As a result, the client will take a stand of a friendly submission. Whatever the recommendation that the therapist will provide, the client will accept that. But in personality disorder, this might not happen. And sometimes it might fluctuate. Initially, the friendly dominant stand can be accepted. You may not know, by the third or fourth session, the client might take the stand of a dominant state, because the friendly dominance of the therapist might create an anxiety in the individual because of the previous attachment experience. So, negative complementarity or non-complementarity is the approach that is being taken by most of the clients, whatever the personality disorders the client is having. It is particularly important for the cluster B personality disorders. So, building a solid alliance is important. Now, whenever I am trying to build a solid alliance, it will evoke some impact messages within myself as a therapist. Impact messages means there might be some emotion that I will experience. I might feel like not seeing the particular client in the next day. There would be some cognition that will continue in my mind. I wish the patient doesn't take appointment for the next day. Or I might engage into some fantasy or daydreaming. Like when the patient is returning home today, let an accident happen. Yeah, this happens. This kind of fantasies happen. And these are all impact messages that we experience. Even we show some of the behavior. The client has sent a crisis message, WhatsApp message, and I do not feel like responding to that. I keep it unseen sometime. So these are all impact messages that might interfere with the building of solid alliance. So it is a test for the therapist also. So the therapist also need to be aware about all the impact messages and accepting those impact messages as part of the process. As part of the process. If those impact messages are creating a significant counter transference, then it is better to discuss with a supervisor to address those issues. But we need to be aware about the impact messages in our emotion, in our cognition, in our behavior, in our fantasy. Ongoing monitoring and maintenance of the alliance is also important. Though I am taking care of the impact messages and trying to address the client in a non-judgmental way, trying to help the client by taking care of my impact messages, but this might not work all the time. So, as a therapist, I also need to monitor myself throughout the process. And if sometimes the client is behaving in a very goody-goody way, it doesn't mean that tomorrow is also going to be goody-goody. So this continuous monitoring and is important, and this is particularly helpful to deal with alliance rupture. Once this monitoring is there, understanding of the impact messages are there, it will minimize the possibility of the therapeutic rupture. And we know, particularly in borderline personality disorder, obsessive compulsive personality disorder, narcissistic personality disorder, these therapeutic ruptures are quite common. Paranoid personality disorders. So, process of change in personality disorder, patient's willingness and ability to engage in the treatment, that is the foremost thing. So we need to assess the motivation of the individual. And there we also need to look for this pre-contemplation, contemplation, action, and whether the client is clear why he or she has come for consultation. And if the client is not very clear, it is our job to motivate the individual through psychoeducation by giving a sick role. Again, how much sick role I will give to a person who is having personality disorder, that also I need to be careful. History of positive attachment relationship, if it is there, that can be a good prognostic factor in the individual. Therapist open-mindedness and flexible approach to therapist, that is also another issue that can have a positive effect on the therapeutic process. Comfort with emotionally intense relationship. If I am not comfortable, particularly borderline personality disorders, because of their projective identification, it is he or she is going to induce a lot of emotionality and lots of ups and downs with respect to those impact messages can be there. So I need to decide whether I am comfortable or not. And tolerance for his or her own negative feelings. I might have negative feelings. मुझे बहुत गुस्सा आ सकता है. I need to say it's okay. It's okay. It's really an interpersonal disturbing situation. So it's okay to feel that. His or her patience. Because as we know that 12, 14 or 16 sessions might not do anything. As I said, it might take 16 to 18 sessions only to form the alliance, a secured alliance. And even after 16 sessions, when I go into the other domain of role transition, interpersonal dispute, and there also the alliance issue might pops up. So the patience is important. A specific training in treating patients with personality disorder should be helpful. A therapist behavior that sets limits and is described as interpersonally active and structured. So we also need to set the limits for ourselves as well as for the client. If the client is being using a lot of followers, that's my value is not permitting. So there also I might, without criticizing, I need to express my discomfort with it. And particularly setting limit in a non-judgmental way actually helps in forming the alliance. Therapist relational stance principle, creating an interpersonal climate that fosters adaptive client responsiveness and relatively high activity level sometimes is helpful. Structuring the treatment, particularly the patients with personality disorders will come with newer and newer crises on day-to-day basis, but we need to adhere to our goal. Okay, for crisis we'll set different time slot, but we need to, so this kind of structuring is helpful, particularly to recreate the autobiographical memory in the individual, because they are already having disturbance in the autobiographical memory system. Setting limits on unacceptable behavior, expressing empathy, showing positive regard, congruence in expression of feeling, including the strategic disclosure. A therapist also can use self-disclosure. If there are similar experiences that of the client, the therapist also might say, yes, I also had similar kind of experiences. At the same time, we need to think about, while we are going for self-disclosing, we might not tell the coping approach. हम लोग का लालच होता है ना कि मैं कैसे coping किया तो थोड़ा बता दो शायद इससे वो सीख जाए. We need to help us to hold back because that might create a rupture for the individual. So the client might say that means you could cope up and I'm unable to. That means you are telling that I'm good for nothing. And transmission of knowledge is also a goal of the therapist. So we'll take the break for lunch. Okay. Then I'll go into the specific techniques for the same. Okay. Before that, any query, clarification?
Generally, when we deal with the PD patients, sometimes we understand then what will happen their behavior, but because they are emotionally unvulnerable. But when in the counseling session, we say there is the possibility of something this kind of happen, and we see that that is also happening in their life. But after session, okay, my last client, she was problem facing is like her husband is a model and cannot give the time to the side. And now the problem is, and he is doing the alcohol. And in our country session, alcohol is not, we are not taking very easily. It's a very thing negatively. Now the problem is when he drink the drink and came here, the girl cannot accept this, and he's doing the too much struggle and doing the fight. After doing part, their relationship become bad, and it's same happened and happened. And but the boys talk is, I cannot quit this because I am doing in the modeling sector, so it's normal for me. So this is happen. I say in my request, I give the last at least 1 month. You give the some space to him and don't any argument. But that time they are doing the same thing every week and come to me and say that I am not following you and I am thinking you will say something back to me.
1 month means maximum 4 sessions. That is nothing. Okay. And second is whenever there is substance abuse, interpersonal therapy may not be that effective for substance abuse, though there are case reports. Even with opioid dependence, it has been found to be when it is interpersonally triggered because many of the substance taking behavior, but the outcome is not that strong for interpersonal therapy when there is the addiction, the pattern. But it takes time. If the type permits, we'll go for a role play. Probably that will highlight how we enter into this process.
Somebody with a PD can be a tricky business. I said, so communicating the sick role to somebody who has a PD can be a tricky business. So if you can just give us an example of how to go about it, communicating the sick role to someone with a PD.
The role play.
Okay.
Then I.
Thank you.
But someone has to volunteer as a patient after the lunch. Okay, thank you.
Okay, before we break for lunch, can we have everybody for a group photograph? It's kind of mandatory for us to have a number of group photographs. So everybody please join. Let's take a group photograph and then we'll break for lunch. Can we do it a little quickly, please? Everyone remember where they stood yesterday? Just take this.
So these are the common factors of any psychotherapy, not only specific to interpersonal the therapy, that stance that therapist can take. Had you lunch properly? Hmm? Though we are talking about the various aspects of interpersonal therapy, but it is one of the most flexible psychotherapy. Only the understanding of psychopathology with respect to the interpersonal problem, that is important in interpersonal psychotherapy. However, and whatever like techniques or skills that you want to incorporate, that is accepted under interpersonal psychotherapy, as there is a lot of CBT techniques, cognitive restructuring techniques are being incorporated within interpersonal therapy. To move further, let us focus on technique and methods of treatment. Therapist modus operandi as a participant observer. And this particular position is actually helpful because of this stand of participant observer, the therapist is recognized as an external real person. It is not that the therapist is acting on something. So the therapist actually mimic the same real person that also client is also playing the role. As a result, the client will inevitably enact with the therapist the same maladaptive patterns of interaction that characterize his or her troubled relationship with others. When I was mentioning that we give lots of focus on alliance building, it is the reason because it gives us lots of idea about the metacognition of the individual, even meta-communication process. I'll come to meta-communication later. So this particular participant observer approach is actually is going to work as an assessment process in the interpersonal psychotherapy. And interrupting or altering this self-perpetuating cycle by the client can bring significant therapeutic change. During this participant observer process, all the maladaptive coping pattern, the interpersonal cycle, all those are going to be there during the therapeutic process, during the alliance building process. And the therapist will try to break that particular self-perpetuating cycle or the vicious cycle, the dysfunctional vicious cycle of that individual. And constructive handling of the negative impact message is aided by a flexible ideographic alliance building strategy. Negative impact messages of the therapist. So, one important aspect during the alliance building process is disengagement of the therapist as well as non-complementary responding is also needed. As I said, this therapy process is going to be quite emotionally overwhelming even for the therapist. If the therapist doesn't disengage, it might reinforce the client, and we need to break the reinforcement habit. So what are the process that you can follow for the disengagement and when to disengage? That is also important during the therapy process. So here you need to remember it is not an error for the therapist to become engaged. However, it is an error to stay engaged. Initially, during the first 1, 2, 3 sessions, the engagement would be needed. Engagement would be obvious. And once the alliance has started working, then the therapist also need to focus on how to disengage. So becoming aware of and leveling the recurring internal engagement and reaction induced by the client can work as a cue for disengagement. So what are the issues that client need to focus on? The messages that I was mentioning, one is the direct feeling, what kind of feeling. Another is the action tendencies or inclination, the cognitive attribution or the thought pattern, and the fantasies. So whenever they will show me the red signal, so that means that I need to not only work on myself, but how to work on myself, right? So I need to begin the disengagement process. So discontinuing enactment of the overt complementary responses is needed at this particular time. I was mentioning about sick role, and at the beginning we are going to give sick role, and in IPT we elicit lots of emotion. Though we need to be careful about personality disorders, about how much affective display we will allow, because sometimes it might be unregulated and it can interfere with the therapeutic process. It can create an environment for the display of anger or frustration. So at the beginning, we compliment the client for each display of distressing emotion. And gradually, we need to stop complimenting the client. Once we are validating, the validation is also a kind of a compliment. But the validation somehow, after few sessions, particularly when those messages are popping up within me, I also as a therapist need to work on giving a pause to the validation process. It is not stopping the validation process. Harmonious and gentle switches between complementary and non-complementary exchanges over the course of treatment may maximize the therapeutic gain. As I said, I need to pause for a while. And it has been seen that at the beginning, if the complement is there, during the middle phase of the treatment, if we can disengage from the complement, and at the end phase of the therapy, again, if you reintroduce complement, that works wonderfully. There might be exception. Okay, whenever you are trying to disengage, some client might create problem because of the feeling of abandonment or feeling of rejection. So that might be there. And as a therapist, we also need to deal with those issues. But at the beginning, the complement would be there. In the middle phase, complement might be minimized or withdrawn. And at the end, or with the progress of the therapeutic process, then complement can be reintroduced. So there we talk about therapeutic meta-communication or meta-communicative feedback. This meta-communication is having two approaches. One is the direct approach, another is the non-verbal or indirect approach, the hidden part of the metacognitive feedback process. So I would like to go for a role play based on this. The volunteer is there. Madam, is it okay for you to volunteer now? Okay? Okay. Please come. I need to chair. And do it and मैडम को पीडी का रोल प्ले नहीं करना बोलूंगा. मैडम माइट टेक आपका नाम प्रीति. ओके. Priti might take the role of a client with depression only. What I'll begin with the establishment of the sick role, then encouraging the affect, and then I'll go for this meta communication aspect. Priti, thank you for to take the role of a role player.
Thank you.
As an actor. And would you like to take some time to think about a role, a lady of your age who is suffering from chronic depression, maybe over the period of 2 years, a dysthymic pattern. And generally in dysthymia, the people are more withdrawn, having more problem with the self-esteem, and having significant skill deficit, interpersonal skill deficit. So if you can assume yourself into that role, and if you would like to take some time to think about that. No. After a minute, we can begin. उसको बंद कर दीजिए ना थोड़ा. Okay. Tell me, how can I help you?
I don't know. It seems like I've struggled with this problem forever. Uh, maybe it's just grown worse in the last few months.
Okay.
I always, I seem to not be able to feel joy or happiness the way I can see that other people feel.
Frustrating.
Yeah, it is.
What else?
And it's difficult to carry on with the day to day activities, my responsibilities, my chores, taking care of the people in my family or the household, and in even at work.
So you're really going through a very difficult time.
Yes.
Okay. And you said that for last few months it is being
Worse.
okay, become worse. So since when it has started?
I would say maybe the last 3 years.
Okay, it's pretty long time. And it's a painful experience for last 3 years, and for last few months it is aggravated. Okay. Can you go back to the period of 3 years when your problem, your symptoms started developing? If you can imagine that particular time, and what might be the factor that started these symptoms?
I think it started around the time when my husband started taking on more responsibilities at work, and which meant more time away from home, away from family.
Okay.
And then we moved cities, which meant I had to give up my earlier work role and start something new, which took a lot of time again.
So because of your husband's more engagement with the work, less
Yeah.
time with the family,
Yes.
so it created problem in your life.
Yeah.
And at the same time, you had to change the city, you had to leave your job, you had to readjust with a newer kind of job here.
Yes. Yes.
Okay. And since then, what are the things you started experiencing?
Initially it was I would say I was not able to sleep very well.
Okay.
My mind would be on a constant overdrive about how I'm most of the time I'm alone, and we don't get to spend enough time as a family. And then
what kind of feeling you had whenever you used to like experience that loneliness most of the time? What kind of feeling you used to experience?
I would feel a lot of sadness and some amount of anger that he's not there.
Okay, okay.
So
Express that.
express what?
Express that those sadness, anger.
I would feel like not getting out of bed in the mornings after waking up. I would stay idle in the bed for a long time and probably cry to myself.
Okay.
And
But you didn't, or you couldn't express to him.
no, I tried to bring it up with him a few times, but then the answer is always the same, that, you know, one has to work, one has to do it for the family.
Yeah, he might be his reason. At the same time, you are also being deprived.
Yeah.
And you were never used to this kind of loneliness. When particularly you have shifted to a newer city, you are already adjusting to the new job environment. During that time, people expect more support. and that was not there. Okay.
Yeah.
If you can remember, though it is around 3 years back, if you still can remember, like whenever we feel some emotions, we feel in some part of the body.
Yeah.
Okay, can you remember where you were actually feeling those emotions?
You mean the sadness and the anger?
Yeah, sadness and anger.
So sadness, I would feel in the pit of my stomach and maybe chest.
Okay. And anger?
And anger, I would feel mostly on the upper back.
Okay.
Upper back.
And what had been your communication to your husband during that time when you felt sadness, when you felt anger, and some discomfort in your stomach and chest and your lumbar area? What did you communicate to your husband during that time?
I told him that probably I was falling sick because this is how I feel. I feel uneasy in my stomach a lot of the times and on my back. Maybe I need to see someone about it.
Actually, feel sick. Actually, you feel sick. Because if I start counting what about the symptoms we're talking about, mentioning about, but you have been feeling low, sad, there have been anger, you have been crying yourself, you are not feeling like getting up in the morning, you didn't feel like doing the work, and you had difficulty with your sleep.
Yeah.
And of late, recently, for the last 5 to 6 months, all those things have aggravated, and it seems that your motivation has also gone down. And all these symptoms, when they stay together in an individual, we, we call it as a medical condition. And this medical condition is known as depression or stress, whatever you want to name it. But this is a medical condition for which you are not responsible. But whenever the person is suffering from depression or this kind of stress, it is going to take a load on the individual. Another time, if you are not depressed, it might be like possible that your husband's more engagement with his work could have been well tolerated. When you are depressed, it is not possible to tolerate that. At the same time, when there are so much of change in the role, there are two change of role, additional responsibility at home, additional responsibility and new adjustment at your office. And as you said, I can assume that probably you didn't have that much of support system within the home too. And in the office also, you didn't know anybody. So there also probably you didn't have any kind of support system. So not only the additional adjustment at home as well as at your office, you didn't have that much of support. You expected your husband could have been more supportive. Due to his own issues, he could not show his support to you. And because of those changes, you started experiencing depression. Okay. I do not want to say that those factors caused your depression. Okay. But they triggered the experience of depression. At the same time, because the depression was there, it is really difficult to adjust. Whenever you shift to a new place, it takes time, 2 months, 3 months time to adjust. But once the person is suffering from depression, it might take longer time, 6 months, 1 year, 2 years, and sometimes people are unable to adapt to it. And here the depression is the culprit. It is not that the kind of weakness that you had probably, but that is not the thing here. And I'm sure probably if the depression was not there, the things would have been more easier.
I think so.
Yeah. So it is the illness that is important. The hope is depression is recovered. And I'm sure once if you can get rid of the depression, illness, things might be different. You might be able to find your own resources to manage your emotions. You might find your own resources to work on the office issues, and even probably um, how is your communication with your husband nowadays?
There's no time to communicate.
Mhm.
So it's mostly on weekends, maybe a Sunday, where we sit down and maybe discuss something.
Mhm.
So it's not going very well. And because of the shortage of time for actual discussions, it often ends up in conflicts and arguments rather than so-called discussion.
Yeah, it's painful. Whenever there is a communication gap, it is very painful to accept that, tolerate that. And as I said, and when the depression is also overpowered, it can induces conflict more. So there is a cycle because of the interpersonal issues. You are suffering more from depression, and because of the depression, there are probably more interpersonal difficulties. What else you are feeling?
At present, I don't know. Sometimes it just feels pointless to carry on, and I wouldn't be dishonest about it, but there are thoughts like, why should I continue to suffer like this? Maybe it's better to put an end to this.
It's very frustrating, very stressful. And Kriti, I can tell you the depression is like this only. And when the depression is there, it will bring the thought that it is pointless to carry on. It makes you more hopeless. And if we do something to treat depression, the things might change.
Okay.
Okay. So, can you tell me about some recent, maybe in this week, a particular episode of communication with your husband?
Yeah. I think the last weekend when we sat down to talk about something.
Okay. Which week it was?
Sunday, last Sunday.
Okay.
And we were talking
It
about,
was in the daytime.
it was in the afternoon,
Okay. Okay. Around what time?
maybe 3,
I'm working on the time boundaries. Okay.
maybe 3 p.m.
Okay.
So we,
And it was a different one or some other place?
no, it was our home.
Okay. Okay. So both of you were sitting.
Yeah.
Okay. Inside
The room,
bedroom.
the bedroom.
Okay. 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 So okay. Then
Then the topic started from the need for getting some work done in the house, interior work for the house.
who started the topic?
I did.
Okay. What you were doing then?
I think I just finished, we just finished lunch and we were just trying to sit around and relax for some
Okay.
time.
I was also doing the same.
Yeah,
Okay.
both of us were doing the same.
Okay.
And I brought up the topic because it was something that we had to get done. And the conversation started from there, but it ended up in,
Can you give me an instance? What did you say?
I said that the house needs work, and I think it's high time that we paid attention to it.
Like,
Uh,
if I'm your husband, I'm not your husband, just imagine. So say to me, whatever you said during that time, say directly to me so that I can get an idea like what actually happened.
Sure. So I said,
You say, okay.
it's been quite long since we decided that घर का काम कराना है. तो I think इस बीच में 6 महीने निकल गए हैं. कब शुरू करना है? It's high time, I think.
This was the tone you spoke? Okay, or you had a different tone?
Pretty much, this is the way it started, but it got worse towards the end.
Okay, can you show me that? How was the tone? Can you give an example?
In the end?
No, yeah, in the end.
In the end, it was like you never have time for me, and all you do is work, work, work. And I think that's like become the goal in itself is to work, but not to support the family or the household. And you know, why do you work so much if you don't have time for me? If we can't have family time, then what's the point in working so much?
Maybe I'm wondering, despite having depression, and as I assume, depression includes a person, still you could speak loudly those issues. And that is really incredible. Okay.
But it led to a fight.
Yeah,
This kind
that
of
might
tone.
be, that might be, but you tried to work on the thing. So after you finish the particular statement, then what happened?
Then initially he was trying to just pacify me by saying it's okay, you're angry right now. But then I think he also lost his patience by the end of it, and he was also shouting back at
The
me.
first thing you said that he was trying to pacify you.
Yeah.
Okay, and how was his tone?
His tone was calm, and
Okay.
he was trying to be supportive, I think.
He was sitting or standing?
He was sitting.
He was sitting. Okay. Then what did you do? Or what did you say when he said so?
I said, don't patronize me. I need you to talk about this with me.
Then what happened?
Then he said that, you're the reason, the family is the reason why I work so much and have to spend time away from you.
What did you
How
feel
can you put it,
when he said
pin
so?
it down on? Sorry?
What did you feel when he said so?
I felt anger.
Okay.
I felt a lot of anger
Where did you feel the anger?
in my arms and my back.
Okay. What you feel like doing?
I felt like just picking up something and just
And
maybe
you, yeah, and you did so?
strike my head with.
Oh, okay. You felt so furious,
Yeah.
so angry, so mad with this.
Yes.
Okay. What did you do?
I did not do that. I just walked out of the room and I refused to talk. Refused to talk anymore.
When you walked out of the room, what did you feel?
I felt dejected. I felt uncared for.
Oh, okay.
And I felt like he wasn't getting what I was trying to say.
Okay. Then what happened?
It just. And then. Then I felt sad after a few minutes had passed. I again went back to feeling the same sad and morose.
But once you walked out of the room,
Yeah.
what did your husband do?
He came after me, trying to see what happened.
What did he say or what did he do?
He asked me if I was okay, and I said no. And he said, no, "Do you want to still talk?" And I said no, because by then I was feeling very, very down.
Okay. Okay. What you actually wanted then?
I wanted probably some display of affection.
Okay. And what kind of goal you had, or what kind of goal you could have been better during that time?
What kind of goal from my end?
Yeah. Or in other way, you can say the way you started the interaction. What was really in mind? What could have been the outcome of that interaction?
I think the goal, a healthy goal that time could have been to just take a minute, take a time out, and then come back again for
That
discussion.
is the approach.
Yeah.
But what did you want to gain out of this interaction? Like you said, no, you begin that particular interaction.
I wanted to be understood, of course.
Okay.
Yeah.
And you had a feeling that you didn't.
No, I
Yeah.
felt I did not feel understood.
Okay. 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 Do you expect that the overall interaction will turn to be in this way, with the feeling of more disappointment, more frustration, more feeling of rejection?
No, I was certainly not hoping for this situation, but it ended up like that.
Okay. So what you actually wanted instead of feeling of rejection? One understood that you said, what else?
I wanted to feel understood and cared for,
Okay.
and I wanted that my loved one should be more present and available for me emotionally and physically both.
How to communicate that? If you want that kind of love and affection, if you need from someone, how do you communicate?
That's a tricky question. Maybe by asking them directly, or maybe by doing that myself with them.
Okay. In this particular situation, when your husband is telling that it is because of the family I am doing so, and that was not acceptable to you. At the same time, you wanted him to show the love and affection. So during that time, what kind of issues, what kind of communication would have elicited this kind of response from him?
The kind I wanted.
Yeah.
Maybe I could have expressed it better that I think we need to work out how we can spend more time with each other,
Okay.
and definitely not when I was angry or sad, but when I was in a reasonably better state of mind.
Yeah. But because of the depression, probably you feel more angry.
Yeah, maybe.
Okay. And the kind of reaction you had during that time, that didn't help the anger to go away, whether you suffered more from within.
Yeah.
So when you are getting angry, what kind of communication could have been good?
When I was feeling angry,
Angry, yeah. What kind of communication you can try?
I could have told him that, look, right now I think I'm flying off the handle. I
Okay.
need a timeout. Just give me a few minutes. Let me cool it off, and then we can resume.
Okay. Okay.
Probably this I could.
What would have been?
I would have been still angry, but at least I think that would have been a little bit constructive.
Okay. That might have like helped you to get some affection and caring from him.
Not immediately, but maybe eventually.
Okay. And to give immediate care and like and display of understanding, what could you could have like communicate?
I could have probably told him that how much I loved and cared about him, and you know, maybe wanted the same kind of response and expression of the same from
Can you say to me the same thing?
yeah.
Say.
You know that I love you and really care about you. And I hope it shows through my expressions. But somehow I miss that in your behavior towards me. And I would really appreciate it if I could see expressions of this.
Is it okay, Preeti? Like if you can exclude that part that I do not get from, I miss that part from you. It appears like a kind of a blame. Is it necessary to blame here? Or if you can exclude that?
Which word?
That I don't think that I'm getting from you, this particular statement that you
Okay.
mentioned. Can it be said without that particular sentence or phrase? Okay, so
Yeah.
try it again.
I would appreciate more emotional expressions from you in terms of how you behave and what you say. I think that would really make me feel happy.
Okay. How are you feeling after saying so?
Good. I feel heard. Like
Okay.
I'm heard.
Okay. Okay. So can you reuse this kind of communication at your home?
Okay.
Is it okay with you?
Yeah, I think I can.
Okay. Do you think that might help to get at least whatever you need during that time, or at least not to deteriorate the situation?
Yes, I think rehearsing would make me feel more prepared when the actual conversation happens.
Okay. I was doing communication analysis. During the communication analysis, as an interpersonal therapist, we can directly go into the role and directly suggest something is something. It may not be the typical role playing that we do in the behavior therapy. It can be like this also. And throughout the process, I was giving her the sick role. It is the depression who is culprit. Because of this, it is happening. And I was focusing more on the emotion of it. Now, Priti, what happens? Sometimes as a therapist, as you said, no, when your husband gave you some feedback and you had the feeling that you are not being understood, you are not being cared, you felt rejected, unloved during that time. Sometimes, even when we are working in the therapeutic process, my intention is to listen to your problem, understand your problem, so that I can help you. But sometimes the people might think that probably I didn't understand or didn't try to understand your issue. Or some of my pattern of behavior might have given an indication that probably I'm also rejecting you. So there can be two issues. One thing, like, I do not want to communicate that feeling to you, but unintentionally that might be communicated. Some things are beyond my control also.
And another issue can be like probably I'm not communicating, even unintentionally I'm not communicating, but sometimes things can be misunderstood. Okay. So I would appreciate whenever you are getting this kind of like communication, or you are perceiving this kind of communication, if you can directly inform me, tell me if this particular use of language or word or this particular behavior that you didn't like, or you had some kind of difficulty with that behavior, that can be helpful for both of us to understand each other, so that I can feel I can help you more. Is it okay with you?
Yes.
Okay. This is one way of meta communication. Okay. The importance of meta communication is it actually helps to build the trust. And it gives the sense of security in the client. And it also, particularly in personality disorder, it helps to create a non-judgmental, non-critical environment. Okay. So this is one approach of working on the meta communication. And another approach is when you get a scope to interpret from the behavior, the kind of issues that she might be focusing. For example, X is maintaining eye contact. Okay. And there is a time she is not maintaining eye contact. So we can take that a cue. Is there something that didn't work in our like therapeutic work? So those are another aspect of the meta communication. So it can be direct communication and it can be indirect communication. Okay. Thank you, Priti.
Thank you.
Would you like to reflect anything on the exercise that we did?
It's hard to play a client. And,
You did a nice.
thank you. Thank you. No, not really, not really. I was.
And I also forget. I started thinking that she is my client.
Thank you. Yeah, probably. Thank you. I think the feeling I had as a client was very. The flow was very lucid. Like the questions that were following one from the next, the succession
Oh, I
of
was running
questions.
fast.
Although that's because it was a role play, right? Yeah. Otherwise, I know that it would have been longer probably. And I think the stance that you maintained was something that I, as a client, felt we were on an equal plane, rather than you being on a higher seat or something.
Did you get the holding? Emotional holding.
Yes, that's what I mean when I say that I felt we were on an equal. Yeah.
Whenever a client is telling something unpleasant, distressing, we need to give something back. That is important.
Yeah.
And that is also a kind of encouragement of the affect. But also includes sharing and processing positive feelings between the client and therapist. It helps clients express immediate feeling towards the therapist. It can be overt or it can be covert. We mentioned those. And it requires follow through. It is not one time affair. Maybe in the subsequent sessions, may not be in all sessions, we need to follow this. To provide a corrective interpersonal relationship that lead to corrective emotional experience. And that is helpful because once it is being created within the therapeutic setup for personality disorder, it can be recreated outside. Now, this is empirically supported interpersonal style associated with personality disorders. So, in For example, in narcissistic, the predominant style is domineering, whereas in unassured submissive type, it is more of a non-assertive. So each of the personality disorders is having a typical interpersonal style that can be evident in the process. So we need to keep that also in our mind while we are working with the client. Now, for other disorders, we have already talked about the 4 interpersonal areas. One is grief or the loss. The second is interpersonal dispute or role dispute. The third is role transition. And the fourth is interpersonal skill deficit. These 4 areas we already know about. But in personality disorder, there is 5th dimension or 5th problem area was identified initially, that is in relation to the self-identity or self-image. Because in all personality disorder, there would be diffusion of the self-image. And this identity disturbance can create affective disturbance that further exaggerate the interpersonal difficulties and create an uncertain or volatile self-image. Now the question is, इतना कुछ बोलने के बाद can IPT treat access to disorder? Empirical support is there for borderline personality disorder and avoidant personality disorders. For other personality disorders, we do not have empirical support. Even the studies in relation to borderline personality disorder, the first study of IPT for borderline personality disorder in 90s, there was 75% loss to follow-up cases. Now, obviously, conclusion cannot be made. Later studies, the first study in 90s, it incorporated only 12 sessions. But the later studies, they found that 12 sessions is extremely inadequate. So they increased the number of sessions. Other than these 2 conditions, we will not consider interpersonal psychotherapy until we are planning some research. At the same time, we need to remember that IPT doesn't claim cure even from borderline personality disorder and avoidant personality disorder. It claims the reduction of the symptom. Now, particularly for borderline personality disorder, if we compare dialectical behavior therapy or interpersonal psychotherapy, there are differential outcome. In dialectical behavior therapy, it has been found that self-harm and suicidality that is being decreased. However, the success is not that much in emotional regulation and impulsivity. And there is not much outcome on interpersonal effectiveness. The way DBT has dealt with interpersonal effectiveness, that is more in the philosophical area rather than the applied area. In interpersonal therapy, the outcome is superior in interpersonal effectiveness and impulsivity. Okay. So probably the combination of both the model can be more effective depending upon the severity of the client, the dominance of particular symptom. Personality disorder conceptualized in terms of dysfunctional interpersonal dynamics, particularly borderline personality disorder, was defined as a mood-inflected chronic illness similar to dysthymic disorder, but with sporadic outburst of anger. So BPD is nothing but a mood disorder with anger. So BPD is often comorbid with mood disorders, and it is partly defined by maladaptive interpersonal behaviors, frantic efforts to avoid abandonment. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation and inappropriate intense anger or difficulty controlling anger. So risk management is another aspect. So these interpersonal difficulties that are hallmark of BPD, it can provide appropriate targets for interpersonal therapy intervention. Connecting these dysfunctional patterns should both improve the patient's life situation and alleviate aspects of the borderline diagnosis. Even some of the recent studies, they have seen that after extensive psychotherapy of 34 sessions, they are no more meeting the criteria for borderline personality disorder. And there is also significant improvement in the CGI, that is Clinical Global Impression score. Presumably, gains in the interpersonal sphere would boost the morale of the patient and lead to generalized symptomatic improvement. Again, I am telling that doesn't mean that BPD is being cured. So, it is being adapted for borderline personality disorder, IPD, keeping in mind the conceptualization of BPD that I have presented initially for all the PDs, and there is overlapping between BPD and mood disorder. IPD therapists often validate patient anger as an appropriate reaction to external circumstances. Initially, we can give this sick role, but later on, we cannot. And encourage the inhibited patient to express his anger rather than to suppress it and feel passive and self-critical. Now, how to express anger? Here, during the therapeutic process, we teach the client how to express it, like we did some activity here. The goal is a moderate and effective expression of anger. So, we go for a decision analysis. What else could have been done? What would be the cost and benefit of it? Patient learns to distinguish a chronic illness from self by taking healthy actions in interpersonal encounters rather than interpersonal action influenced by the symptoms of illness. The patient begins to see how chronic illness has inhibited his or her interpersonal skills. We give detailed psychoeducation for that, and whenever we do those role plays or activities, that also can be quite helpful. Symptoms and symptomatic interpersonal behaviors become ego aligned, and developing new skills then yields success experiences, better interpersonal functioning and better mood, and the resolution of the iatrogenic role transition is the setting of the long-standing diagnosis. Why iatrogenic role? Because what happens, the role transition happens in a subsequent sequential process way. Today I am into some relationship. Okay, and there had been some interpersonal conflict. I broke because of the devaluation, I broke the relationship. So that is also a role transition. Again, after few days, I am again into a relationship. Another role transition. Then broke the relationship. Another role transition. So this sequential process continues within them. And it is the therapeutic job to minimize those creation of role transition. However, they are having difficulties in forming and maintaining a treatment alliance, and patients notoriously tend to split or think dichotomously even with the therapist. The goal must be ultimately to help the patients integrate mixed feeling, the positive and the negative aspect of inherent in all relationships. So create an ambivalence, that is the goal. Okay. The therapist validates the patient feeling, but then probes for negative feelings in positively held relationship or vice versa. If a rupture occurs, the therapist validates the patient's feeling when possible, encourages active communication of the disagreement in here and now, interpersonal terms, and underscores the importance of continuing to work together. Now, what are the issues to consider in the therapy? First thing is subjects with BPD, because of their pervasive instability, often show a scarce compliance, marked intolerance of stress and frustration, and poor identity cohesion can be there. So they cannot tolerate long-term psychotherapies that adapt explorative technique and strict boundaries of setting. Like in DBT we do. It takes 2 years of therapeutic process. And there are individual sessions, there are group sessions also. However, interpersonal therapy can be concluded within 8 months of intervention. That is much lesser than the DBT, the protocol. Often develop a relational dependency with fear of abandonment that may be elicited by too long-lasting treatment modalities. So, in DBT, the dependency possibility is higher than the short duration therapy. Or in the other hand, time limited intervention can be too short to obtain. So, IPT, the shorter version, the 15-16 sessions cannot be helpful. Even brief IPT cannot work. Brief IPT is of only 8 sessions. The risk of self-mutilating behavior in suicide is another element. And that was not part of IPT initially. So that was incorporated for risk reduction. An opportunity to contact therapist during the crisis outside the session may prevent acting out and self-damaging conduct. In DBT, what happens? The skilled trainers for DBT, they are not focusing on the crisis intervention. There is a separate team for crisis intervention. Here, the therapist only take the role of crisis intervention with some limit setting. I'll come to the limit setting later. On one hand, BPD patients require a measured setting flexibility. On the other hand, well-defined boundaries of the therapeutic intervention should be explicated to the subjects at the beginning of the therapy to stem their manipulative attitudes. So, first thing that we need is assessment. Huh? They generally think in dichotomy. Okay, good or bad. We want a mixture of both. Some is good, some is bad. That we call ambivalency.
But okay, so then how would it lead to a good prognosis in BPD patients?
Because it's more the dialectical approach is there. It is not only good. You are a very good person. Next time you said something, criticized me, you ask this particular person, you have become a bad person. So, how much would be my suffering? What would be my interpersonal interaction with you? But instead of, yeah, you are having some good thing, you are having also some bad thing. How much acceptability I will show to you? So, it is creating the ambivalence. When there is too much of splitting, we need to bring to them into an ambivalent state where the person is a mixture of love and hate.
Do we do this during role play?
Yeah. Through role play we do generally, or sometimes through direct guidance also do. And with this meta communications also, we communicate that. So assessment, the best tool for assessment is the history. We need to take the detailed history, also the history of that. And the second best tool is the observation during the interactive process, how the individual is showing the emotion, the thought, the somatic manifestations. So those observations are also important. And also we need to do certain formal assessment. One thing is the emotional assessment. The depression, anxiety, anger, particularly this emotional assessment. And if there is any other comorbid condition like OCD, that also need to be assessed. The second that assessment we do is the metacognitive assessment. For metacognitive assessment, interview itself can be beneficial. And if you want, we can use tool like metacognitive questionnaire to have an understanding metacognitive state. Third assessment tool that is important is IIP, Inventory of Interpersonal Problem, IIP 32. That is a good tool to identify the kind of interpersonal issues. And another most important is interpersonal inventory. Interpersonal inventory. The question related to the interpersonal inventory are important. And we also assess suicidality of the individual. For grief, the focus should not be retelling of events of the loss for BPD. Who are having axis 1 problem with history of grief, there we go for retelling of the events of the loss. We allow the individual to mourn the loss process. But here in borderline personality disorder, we may not repeat the same, because it can create further vulnerability for the individual. More on the effects of the social support structure and how to develop new ones. That is the focus. In the interpersonal circle, we try to elicit what are the needs that used to be fulfilled by that particular individual, and who are there in your interpersonal circle, up to some extent at least, who can fulfill some of your needs, and how to create the relationship or the bond with them, how to seek support from them. That is the focus. For role transition, the IPT therapist guards against becoming involved in exploring an ever increasing number of role changes. Because every day they will come with newer role, that the relationship that I mentioned, no. And the therapist should not become involved in trying to solve the frequent reports of disputes. Because in BPD, the most common issues they will come up with the dispute and the transition. The therapist is cautioned against encouraging excessive display of affect related to a dispute. So we go for a diagnostic formulation first in the therapeutic process, and this diagnostic formulation is based on interpersonal approach. Individuals' wishes, inclinations, goals, support system. Based on that, we need to go for a diagnostic formulation. And then we try to work on the therapeutic alliance and the risk management, particularly if there are risks for self-harm or risk for harming others. So in the beginning sessions only, we also introduce the interpersonal inventory. We try to get the details of all the 4 domains of grief, dispute, transition, and interpersonal skill deficit, and how those issues are related to risk. Because in most of the time, the risk behavior, be it violent behavior or suicidality, they are interpersonally triggered. So we try to identify those factors so that things can be worked upon to minimize the risk. Then we try to assess the self in relation to the others, in relation to the past and relation to the present. And we also do a detailed communication analysis. And patient therapist relationship exploration continues, alliance building continues throughout the therapy process, and the communication analysis also continues for them. And we also, at the later phase, we introduce this meta communication. And then finally, we focus on the schema, that is focusing on the abandonment, and then we go for a termination plan. But this termination plan is extended, unlike in other group of clinical population. Here it is extended. In IPT, particularly focuses more on the termination, because termination is also a kind of a loss experience, an interpersonal loss experience. So there is a possibility of experience of grief during the termination phase. So we facilitate the mourning process in the termination. So in the initial phase, we generally introduce with the medical model, that the diagnosis. We can use some the checklist also to identify what are the BPD symptoms are present, so that we can keep a track, and we also can take the intensity of those symptoms, so that we get to know the reduction of the symptoms. And then we introduce the IPT based model for the BPD. Then we go for the therapeutic contract, that includes the length of the session, how many sessions are needed, how frequently, what would be the duration of the session. In general, 50 minutes duration is used. And you also tell about those crisis management, how frequently you can give me a call, how many calls are allowed. 2 calls in a week is allowed, maximum up to 10 minutes. 2 calls in a week is allowed, maximum up to 10 minutes. And within this 8 months of therapeutic process, maximum 2 hospitalization for 7 to 10 days duration may be thought about. And these calls are only allowed when the client is feeling suicidal but have not done anything. If the client has already done anything, then he or she is not supposed to call the therapist. And he or she is supposed to go to the general physician. And we also help them with necessary reading materials, and also there are some websites that give some understanding, work as a support group. Those details also can be given to them. And then we focus on the relational aspect of BPD, and that is the primary focus. That includes the relationship with the therapist. And therapist is friendly, positive, hopeful, and encouraging, and repair ruptures in the alliance whenever it comes up. At the same time, you work on the boundaries. Some of the boundaries I just mentioned, how frequently can be called, when to call, when not to call. And we also use the interpersonal inventory. Like some of the questions of interpersonal inventory, but unlike depression or other issues, there we generally focus on last 1 month. Here we generally focus on 2 years, past 2 years. So that is the thing that you need to remember. If the data of past 2 years is not available, at least for the past 6 months. So what the important people in your life? What do you like about the relationship? What don't you like about the relationship? What you don't like about the relationship? What has changed in the relationship? Are you having difficulties in this relationship? So he asks, these are the sample, the questions, like dispute related question. What do you and your husband fight about? What do you fight? How do your fight ends? How would you like your husband to respond to you when you are angry? So this gives a good idea about what is happening. And you also use the interpersonal circle to draw. So relationship interaction must be stressed carefully to any risk-taking behavior. So therapist monitors symptom change throughout the therapeutic process. Also needs to review relationship over the past week, because these risk-taking behaviors are short-term, and in most of the time they are interpersonal triggered. So if something is troublesome, that we need to address. Avoid interpretation of the therapeutic relationship during this process. Therapist appraises the therapy itself and reviews the goals and the tasks set out early in the therapy, rather than taking the new goals in the subsequent session. And therapeutic relationship are understood through a communication analysis. Therapist may need to accept that he has made an error or been insensitive to the patient's state of mind if somehow he communicates that. The focus of the therapy is to distinguish between the illness itself and the personality. It is also a kind of a role transition. And most patients with BPD had role dispute and role transition, and each session commence with a review of the current relationship and interaction with others, followed by a communication analysis whenever it is appropriate. Patient being asked to monitor interaction between sessions carefully. So we also assess the conflict graph. On one axis, it is the importance of the relationship, and another aspect, the severity of the dispute. And we prepare a graph keeping in mind all the important persons with the person. And obviously, we need to focus on where the importance of relationship much. We can work on those conflict first. So how to manage the high risk behavior? It is essential to ensure that the therapist is practicing in an appropriate context. That is important. So sometimes supervision can be helpful, and the patient is offered additional support when there is a necessity. Even taking the GP support is helpful. And the crisis need to be managed within the general psychiatric service and a pathway agreed between the patient and therapist before crisis comes. In the therapeutic sessions only, we need to decide upon if it happens, what are the pathways. And suicide attempts and self-harm or thoughts about them are addressed throughout the treatment. Two aspects are explored in the therapy: the interpersonal event associated with self-harming act and an exploration of the patient's emotional state and sense of self during the relationship. And patient is allowed to contact the therapist on the phone to discuss the crisis as long as it has not resulted in a destructive, either to self or to others. A patient cannot contact a therapist after a suicide attempt. Such telephone contacts should be for a limited time only, around 10 minutes, maximum 2 times a week. So initially started with 12 sessions. Later on, it was proposed that 24 sessions might be needed. However, it was found that the long-term outcome may not be obtained with 24 sessions. So it was proposed either 32. 32 means 16 plus 16 session. 16 session for alliance building, 16 session for therapeutic work. And later on 34 sessions, that is 18 sessions for alliance building and 16 sessions for therapeutic work. And additional 3 sessions may be considered for termination if termination cannot be done within these 16 sessions. Additional 3 sessions may be considered with monthly follow-up, at least for next 6 months. 50 to 60 minutes weekly session, and termination, as I said, is also a loss experience, and it is also known as bittersweet role transition. And there is one study that highlights the role of incorporating interpersonal therapy group after the end of 34 sessions. After the end of 34 sessions, if there are another 16 sessions of group therapy with 6 sessions in each group, it has been in that even after 2 years of follow-up, the patients are not fulfilling the criteria for borderline personality disorders. But obviously then the total number of sessions would be much higher. But still it is less than 2 years duration. And another addition is interpersonal counseling, particularly if there is partner or the other family members, there for them interpersonal counseling may be given to psychoeducate them and what kind of interaction they can work on, how they can validate the client. For interpersonal 6 sessions can be thought about, and that can help. That's all about management of PD. Any query, clarification?
Yes, query.
कुछ समझ में नहीं आया या सब समझ में आया? Nothing. At what time we are having break? Now or later? After this. No query. Okay. Will you please stand up? मैडम नहीं है. किनको किनको खुद का साइन करना नहीं आता है? आता है? Can you sign with your right hand? Do on the ear. Okay. Can you do it with the left hand? Okay. Can you do it with your head? हिल नहीं रहा है क्या गर्दन? Okay. Can you do it with your right shoulder?
नींद दूर करने के लिए है.
With your left shoulder? Okay. Can you do it with your buttock? करो करो. Can you do it with your both the knees? दोनों पैर को उठा के कर सकते हो सही? सिर्फ बैठ जाओ. A brief presentation on IPT as evidence-based practice. So many things already has been said. Nothing much. There are empirical support for major depressive disorder. IPT is one of the most regularly studied therapies for depression. There are over 40 RCTs, randomized controlled trial, for IPT that shows its efficacy in comparable to cognitive behavior therapy and pharmacotherapy. Latest studies have shown that it is being efficacious for the management of chronic depression like dysthymia, even relapse prevention for bipolar disorder, depression, particularly bipolar depression, and perinatal and postpartum depression. For bipolar disorder, it has been seen that the person who had been suffering from bipolar disorder, for them maintenance of the asymptomatic phase, IPT, that is IPSRT, interpersonal social rhythm therapy, that is based on social Z-Geber model, that has been effective. Not only that, the adolescent who are vulnerable for bipolarity because of the family history, because of soft bipolar sign, there also it has been found to be effective. For postpartum depression, it is suggested that IPT is the first line of defense. For eating disorder, though it has been tried with anorexia nervosa and there are good outcome, as well as bulimia nervosa. However, for bulimia nervosa, it is being found to be more effective. Though effects are slower to emerge than cognitive behavior therapy, however, the effect is long lasting for interpersonal psychotherapy. For PTSD and grief, there are emerging evidence support IPT adaptation for trauma and complicated bereavement, and it is emerging as an alternative to trauma focused cognitive behavior therapy and exposure based trauma intervention like EMDR, critical incidents debriefing. Everywhere, be it eating disorder and PTSD, the focus is interpersonal. And it is being recognized by the various professional bodies, including American Psychological Association, American Psychiatric Association, National Registry of Evidence-Based Programs and Practices, and NICE, that is UK National Institute for Health and Care Excellence, particularly for the management of depression, and now for the management of borderline personality disorders. It has been found to be efficacious. If you look at this table, IPT efficacy by disorders, the evidence is strong for major depression, as well as postpartum depression and bulimia or binge eating disorder. It is also being strong for adolescent depression. However, there are some modification in adolescent depression. One modification is, as I said, that we give lots of sick role. But for adolescent depression, we are not supposed to give that much of sick role. Because once they start taking the sick role, the motivation will not be there to come out of it. So we might give some initial sick role, but we need to withdraw that sick role. And second is incorporation of the family members in the adolescent depression through interpersonal counseling. There are moderate evidences for bipolar disorders and PTSD. However, for personality disorders, it is emerging. There are 5-6 studies only. If you look at this interpersonal psychotherapy for various mental health problems, this is published in 2016. It shows that even the depression, anxiety, and well-being in relation to the breast cancer patient and in myocardial infarction and associated depression, mood disorders, there the response has been quite positive for this problem. However, there are ethical issues and cultural competencies as IPT practitioners that you need to remember. The first thing is the boundaries and dual relationship. And the challenge is IPT places strong emphasis on the therapeutic relationship, which may increase risk for boundary testing or boundary violation. So, at the very beginning of the therapy, the clear boundaries must be maintained to avoid role confusion, especially in patients with personality disorder who may test your limits by idealizing, creating dependency, and obviously it is common for all therapies where we need to avoid the dual roles. Second issue is confidentiality. There are standard ethical obligations to protect client privacy and particular care when conducting IPT in group or family context or in a small communities where anonymity is harder to maintain. It is particularly important once you administer the interpersonal inventory, you get to know lots of the detail of the individual's interpersonal position. At the same time, during the therapeutic process also, during the working on the alliance building process, lot of intimate issues might come up in the interpersonal domain, and you need to be particularly careful. It is more important for adolescent depression or any other individuals who is minor. So there the confidentiality issues might be focused on, and be explicit about the limits to confidentiality also. There are some client who assume that the person has done self harm, and this will not be disclosed. So we need to mention what to say, what not to. So informed consent is needed to ensure clients understand the IPT model, especially its focus, time limited nature and structure. I need to provide information about adaptation and any deviation from the manual. For our client, it might not be that much issue, but at the same time, there are some clients, whenever they think about, I can remember, like I use a lot solution focused breath therapy. Some of the clients whom I need to see online particularly, and they are mostly professionals or faculty at some other place. And on the very first day, once I say that, okay, I'm assuming a solution focused breath therapy approach, and just see whether you want to will be comfortable with that. And the very next day, I see that they have already read a lot about solution focused therapy. And in one day, we are not doing research with therapy. In one day, I have deviated from the solution focused model. I went to a teaching modality, okay, of particular skill that is not part of the solution focused therapy. The client says, you are not supposed to teach me something. So they know. Competence and scope of practice, like deliver IPT only properly trained and supervised. Recognize when IPT is contraindicated. Where it is contraindicated? In psychosis. In psychosis, it is contraindicated. It's not indicated because of insufficient data. Or severe substance abuse also, it is contraindicated. So refer or collaborate when specialized care is needed. For example, if there is a psychological trauma, neurodevelopmental conditions, there we need to focus on, particularly ADHD. And risk management, it often brings up sensitive interpersonal issue that can escalate distress, and that can create a problem for the client as well as the therapist. So have protocol for suicidality, self-harm and crisis intervention, especially with high risk population. And we also need to take care of the cultural and social sensitivity. There are challenges like misinterpreting interpersonal dynamics through a Western individualistic lens can lead to ethical misjudgment. And the best practice, integrate the cultural competency and humility into case formulation, and seek supervision or consultation when working with clients from unfamiliar backgrounds. Therapist reaction and counter transference is another issue, because interpersonal patterns can provoke strong emotional responses in the therapist itself, particularly whenever dealing with PTSD and personality disorder. The best practice is to use supervision to manage counter transference. Second, maintain self-awareness and reflective practice to avoid ethical drift or reactionary decision. Now, with respect to cultural consideration, we need to go for culturally responsive interpersonal formulation, particularly if you can remember the biopsychosocial model. In the social model, we also incorporate the cultural factor. Dr. Gitanjali from Nimhans has published a case study on interpersonal therapy. There also I saw that in the model, she has included spirituality also. So recognize how culture shapes relationship, norms, emotional expression, help-seeking behavior, and expectation of therapy. Ask open-ended questions about the client's cultural identity, family roles, community values, and interpersonal expectation. I can remember like a lady came to me, she was brought by her husband from Muslim community, educated, both of them are educated. The lady has passed post-graduation, but non-working, homemaker. And she came with the symptom of depression. That was evident for last 5-6 months. And we assumed the interpersonal therapy for her. The problem came that I am going to work with her in a closed door. That was unacceptable to the husband. So I had to talk to husband about that. Because we found there was role dispute and role transition. And one of the major aspect of role dispute was with the husband. And husband is sitting there, it is difficult to work on. And the role transition is, she is not being allowed to do any kind of pleasurable activities. She wanted to take some tuition classes. She wanted to learn swing. Nothing was allowed. So there was huge role transition. And they were planning for a baby also during that time. And there had been recent interpersonal dispute with her parents. So that connection is being cut. So lots of interpersonal issues were there. So there, the first session we had a joint session where separately I had to talk to husband, the interpersonal counseling, how he can be supportive. After detailed psychoeducation, giving her the sick role and how he can be one of the important stakeholder or the partner for the improvement. In the second session also, we had joint session. We didn't go for communication analysis and other issues, mostly supportive modality we are following, giving her the sick role. Started engaging in some pleasurable activities. So once in the second session, husband found that it is non-threatening. Third session onwards, it was allowed. And after fifth session, husband didn't come also. She used to come alone. So we need to focus on the cultural aspect of adapt your problem area selection and formulation. Like what might look like a role dispute in one culture may be seen as a duty or tradition in another. Inclusion of cultural identity in the interpersonal inventory might be helpful. Actively explore how cultural, racial, religious, gender, and socioeconomic identities influence the client's social role and relationship. Understand power dynamics in interpersonal context and validate the client's lived experience of discrimination, marginalization, and acculturation stress. We also need to focus on cultural humility and the self-awareness. It is not just the competence. Be open to learning from the client and aware of your own cultural biases. Reflect on how your personal values, worldview, and privileges may shape your interpretation of the client's relationship. Use supervision or consultation when working with unfamiliar cultural groups or when you encounter cultural counter transference. I'm seeing a boy, he's Bengali, but since his childhood he has stayed in Canada. And there had been history of addiction, and he was taken from there. The parents are staying in Kolkata, and now once he came to me, the way I started working on the therapeutic process, it seemed to me that probably it was working well. On the third session, he only communicated some disagreement, and it was based on his cultural view. So sometimes it can create a problem, create an issue, and the disagreement was amounting to the discontinuation of the therapy process. So adaptation of communication style is also important. So respect culturally normative styles of communication. Like in some culture, there can be more silence. There can be more indirectedness. People might not look at your eyes. There can be difference to authority. So adjust your use of emotional language in interpretation of affect. Be mindful of language barriers, and when necessary, you can use trained interpreters, but not family members. So culturally sensitive use of IPT techniques like modify psychoeducation to reflect culturally relevant values and metaphors. Like instead of depression, use of stress is more acceptable to some people. Sometimes as pre-assessment, I use GHQ instead of BDI or HAMD, because the full name is Hamilton Depression Rating Scale, and it is general health questionnaire that is more acceptable to it. Even IPT, it recommends to go for GHQ instead of BDI. Normalize emotional struggles using culturally congruent frameworks and frame role transition dispute in terms of cultural script. For example, immigration, coming of age, marriage, caretaking, all those issues. As I work in a government hospital, we see many patients who are 14, 15 years of age having a child. Yes, 14, 15 years of age having a child. And you also get many cases who has got married at a young age, having a child, and during this childbirth process went to the hospital, and they have come out of the hospital with a POXO case. It's a minor. And having a child means there is sexuality. And the girl is minor. So the hospital, there is mandatory POXO case. Now in the therapeutic setup, we are in a confused state. So their cultural pattern, the kind of economic background, the social background, they are coming. Particularly this particular, the ladies, they come from the Sundarban area, and the trafficking is very high in the Sundarban area. Young female trafficking is very high. So once they are 12, 13, 14 years of age, parents start thinking about getting them married. Otherwise, they don't know when they would be trafficked. So there is this social crisis. So it is basically a kind of a harm avoidance. Marrying them is a kind of a harm avoidance rather than like illegal activity. So we need to focus on many role transitions issues here. Those are culturally congruent. Flexibility in delivery. Consider alternate formats like group IPT or community-based sessions for some, if they better align with cultural norms and increase access. Be sensitive to cultural perception of time, authority, and therapy itself. Adjust pacing or the session structure accordingly. So we need to look at IPT cultural competency checklist. There are skill area like explore cultural identity, understand cultural expectations, clarify idioms of distress, modify problem area language, and use supervision for bias awareness. So these are some of the things that we need to focus on. So key consideration for IPT in Indian cultural context. One is independence and family-centric role. Indian culture emphasizes collectivism, duty, and family roles over individual autonomy. And role dispute or transitions often involve extended family, in-laws, and the multi-generational expectations. So therapeutic challenges are like client may not see relational conflict as psychological issues, but as obligation or destiny. An IPT strategy is to frame conflict as a relationship stressor, not pathology. For example, how are this expectation affecting your well-being and relationship? Instead of here, affect encouragement will not be the focus. Authority, hierarchy, and respect. So difference to elders, teachers, and male authority figure is common. Assertiveness may be perceived as disrespect, especially in women or younger clients, particularly in the northern part of India, northern western part. IPT focus on open communication may need to be tempered to fit cultural norms of indirectness. The adaptation can be work on negotiation strategies within respectful communication rather than pushing for direct confrontation. We are also having lots of stigma around mental health, and that also can interfere with the therapeutic process. Most of the time, the client they do not decide for the therapy. So psychological symptom may be expressed somatically and spiritually. So seeking therapy may be considered as sign of weakness or a family failure. So the strategy is normalize therapy as a problem solving tool rather than a treatment or not a sign of an illness. Emphasize functional improvement in family and society. Role transition unique to Indian context. Arranged marriages, dowry related stress, joint family integration, migration for education or work, and caregiver burden are the common themes. This transition can be emotionally intense with limited autonomy. IPT adaptation use role transition to help clients grieve the old role and adjust to the new one while respecting traditional values. Religious and spiritual belief, Hindu, Muslim, Sikh, Christian, or other religious framework often shape the understanding of suffering, healing, and relationships. Some may prefer religious or spiritual guidance over psychological explanation. The strategy is collaborate respectfully with the spiritual meaning system. Ask, how does your faith help you make sense of what's happening? Language literacy and accessibility. The material must often be translated into the regional languages. That is helpful. Use of culturally relevant metaphors and idioms and stories help engagement. Advantages of IPT in India. The interpersonal model matches the relational worldview in India. Its structured, time-limited nature fits well in overburdened public health settings. And IPT can be taught to anybody with minimum understanding of mental health. Not IPT, interpersonal counseling. Even in Goa, this Sangat NGO, they trained 3,000 self-help women group on interpersonal counseling so that they can identify and provide necessary counseling for the women under distress. IPTA and the group IPT have shown promise in rural and low resource Indian settings. Even my PhD is on IPT. IPT components in eclectic use. There are some point in CBT, the relational issues can be addressed with interpersonal therapy. Interpersonal stress and associated cognitive distortions are common. In DPT also, the interpersonal effectiveness domain can be fully worked through based on the IPT modality. In psychodynamic therapy, see, there are only two therapeutic approaches that primarily focuses on emotion. One is psychodynamic therapy, another is interpersonal therapy. Now, emotion focused therapy is also focusing on that. So, in that way, psychodynamic and interpersonal therapy are very similar. And some people have proposed the interpersonal therapy is also a kind of a psychodynamic therapy. But it is not, because the interpretation is not there. However, the many of the conflicts that arise in the interpersonal domain, which is very similar to IPT. In ACT, acceptance and commitment therapy, there this role transition can align with the ACT value-based action planning related to the behavioral goal they decide, so that can be incorporated. In MCT, metacognitive therapy, in MCT, the overall metacognition is having its contextual meaning in the interpersonal domain. So there are many interpersonal therapeutic strategies that are being incorporated for MCT for the borderline disorders or the other personality disorders. Even in trauma-focused CBT, the interpersonal system can work as a support system. And many a times in trauma, there are issues of mistrust, feeling of lack of safety. Their interpersonal therapy can create a secure base for the individual. The therapeutic relationship equivalent to interpersonal therapy can help to come out of the trauma. And mentalizing based therapy is also very similar to the metacognitive approach, more activity oriented, interpersonal activity oriented. So there are many commonalities with various psychotherapy, and those can be incorporated here. And there are some core IPT components in eclectic use. One is interpersonal inventory. Even we are not doing interpersonal therapy, but if we use this inventory, it can work as a very good discovery tool, because it can give us a description of the problem, emotions. And these problem areas are very common as life events for CBT or for other problem areas. Communication and decision analysis can be a good tool, particularly for interpersonal conflict management. Use of emotionality, use of affect. CBT sometimes might fail, particularly in the rural population, because of the primary focus on the cognition. But if you can bring the focus on the affection, that can be helpful. And the socio-cultural framing in this biopsychosocial model. that can give us a better understanding of the psychopathology to formulate the pathology formulation. And the mourning, the termination considering as a loss experience. So if you can facilitate the mourning, what are the things you are going to miss? What are the things you have learned? So that can be another important component for any of the psychotherapies. So when to consider integration for complex cases? If non-responsive to IPT alone, client preference or cultural fit for more or less structured modalities, and multidisciplinary teams or stepped care models. It is easy to follow IPT for multidisciplinary team than CBT. And there are some pitfalls to avoid, like merging too many models without coherence. That is also important. And ignoring therapist training boundaries. And failing to explain to the client how integration supports their goal. The client has to be convinced about that. Otherwise, client has to remember so many models, and that can create more confusion. Another integration we need to think about, IPT is based on a theory, but it doesn't have a specific personality theory. And most of the psychotherapies are having specific personality theory. So we call it, instead of calling or taking as a eclectic approach, assimilative approach can be more appropriate. We are incorporating some aspect of this therapy, assimilating with some other form of therapy. Limitation and ethical risks, dilution of IPT model, using IPT light risk, abandoning its theoretical grounding, leading to eclecticism without coherence, and loss of fidelity, staying from the core problem area, हट जा सकते हैं. And there can be training gap that can raise concern about ethical and competency issue. And there can be inconsistency in formulation. And even as a therapist, we might be confused when there are different types of formulation. Thanks. This is the end of my lecture.
We can take question and queries. Now I would like to call Ms. Sonia Puar for the vote of thanks.
Thank you, Sneha. It is my first privilege to deliver the key highlights of the CRE program that we have right now just concluded. This CRE program, Interpersonal Therapy, Transforming Clinical Outcomes, dated 8th and 9th May 2025. Thank you for all of you to join us and make this a success. The aim of this CRE was to disseminate awareness, knowledge, and skills in understanding and application of evidence-based therapy, interpersonal therapy in various clinical conditions. I hope we've been able to fulfill that aim for you all. Thank you for the nods that I can see. The topics covered were basic understanding of interpersonal psychotherapy, understanding depression from a interpersonal lens, practice of IPT in depression, management of grief and bereavement, practice of IPT in anxiety, understanding couple dynamics through IPT lens, interpersonal psychotherapy in marital and couple counseling, practice of IPT in personality disorders, ethical issues, and cultural competence that is required as a practitioner of IPT. I hope you all have benefited from these topics. These topics were thought over with much deliberation that our participants should make the most of these. The speakers for this CRE was Professor Dr. Kalpana Srivastava, Director IDAS, Dr. Prashanta Roy Kumar sir from Kolkata. Thank you, sir, for joining us. Ms. Rashmi Pandey, Ms. Sampurna Chakravarti, Ms. Neha Das,
who were in-house speakers delivering such knowledgeable lectures on letting us know the nuances of interpersonal psychotherapy. The total number of participants was 140, and we are very happy to have some of our alumni with us today, yesterday and today. Thank you for joining us. The participants have come from different various states, Uttar Pradesh, Delhi, Haryana, which is like the NCR, but we also have people from Punjab, Jammu. Thank you for joining us, and we wish you have a safe journey back home. And given the conflict that we are in right now, let's pray for everybody's safety together. People have joined us also from Rajasthan, West Bengal, Gujarat, Maharashtra, and Karnataka. Thank you for taking out time and traveling to our university and being part of this CRE program. The key organizations where we have participants from, and we're very happy to have you all here, are from AIMS New Delhi, AIMS Kalyani, KGMU, Winhans, IISS Bangalore, and a lot of reputed private organizations like Amaha, Lysen, Sukoon, Max Healthcare, and many of you who are in your own right very good practitioners doing individual work also. Thank you for joining us. Some of the key takeaways that we have been there is that I think we all have understood that IPT offers a structured and time-limited focused approach. It's based on the biopsychosocial vulnerability, attachment, communication patterns, and interpersonal stress model. It also is important to understand that it has its limited role. It has been applied in various disorders, but let's not call it as, again, I think Prashanta sir very beautifully mentioned that IPD does not claim cure. So let's be mindful and not really take it from any other perspective, but be truthful to what IPT has to offer and use it where it's most applicable in relationship disputes, relationship transitions, grief, and loss. Okay. In India, IPT, interpersonal relationship, and social milieu is of utmost importance. I think we all understand we are a community which, we are as a nation, are more socially connected people. Social connections mean a lot to us. Our identities are dependent on social connections. We do form our happiness from social connections. Humans are social beings. Therefore, IPT has its own advantage in our setting. But however, the efficacy is, in terms of the research, is limited because researchers are limited. Not because it's not effective, but researchers are limited. So we would encourage if people can take up more researches in this area and provide us with more home-based research material rather than just saying it's applicable in this population or it has been found from that country, but also have Indian research coming in. That's also one of the key takeaways, that if people who are planning their PhDs or working around research can think about these areas, that'll be really wonderful for us also, and that'll be a success of this program. These were some of the highlights and key takeaways. We would like some very basic feedback. If there can be just one or two people, or maybe about 3 people who can just tell us a little feedback about how it's been for you. These 2 days have been for you. If you can, we can have volunteers for feedback, please. We'll really like to hear it. Okay. Everything was great here. Sahil, can you pass the mic over there, please?
I would like to congratulate the faculty for organizing such a wonderful and enriching experience. It was truly delightful and a very learning experience, actually.
Thank you. Can we have a few more, just if anything where we could improve
We would like to hear that also, so that we can keep it in mind for planning our next CREs. Can we have just one or two more people, please? Here, there.
Hi, this was my first time knowing anything at all about IPT. I've never practiced it, and I can definitely say that I'm going back learning a lot from all the speakers on both the days. So thank you so much for that.
Wonderful. Thank you so much. Anybody else wants to say anything? Maybe one area of improvement if we can also have. It'll be nice. Or just your experience. How was it for these 2 days? Just your experience is also okay. Nobody has to feel the pressure. Maybe some of the seniors with us, if they can share their experience, we'll be really happy to hear from you all also. Sahil here.
You. It was really very nice and enriching, except that there was so much of information that was given to us. So maybe you could have extended it by another day.
Okay.
Yeah. Because in the sometimes there's information overload, and we are trying to process it and we are trying to understand it, and you go back and maybe in your practice setup as well, you want to use it. So at times it does create confusion. After all,
I
it's
get it.
human brain. So if you could have it for another day, it would be so much more better.
Thank you.
Very
so much.
nice, yeah.
Thank
And
you.
excellent speakers and a lot of content given to us.
Thank you.
you.
Thank you for sharing that feedback. Really ups our morale. Thank you. Okay, without further ado, let me do the formal vote of thanks also. With this, we conclude the CRE program. I would like to extend my sincere thanks to our respected founder president, Sir Dr. Ashok K. Chauhan, sir, who has provided us with this platform of Amity Universe, where we are able to undertake these academic endeavors and engage in academic deliberations. Thank you for supporting us and always helping us, sir. Our very dynamic Chancellor, Dr. Atul Chauhan, sir, again for creating standards that we meet. So I think I heard somebody say that these CRE programs are way above standard than other CRE programs that are being conducted. That's because we don't really do a shoddy job. We make sure that academic standards are maintained and met. And Dr. Atul Chauhan sir is our inspiration to keep the standards high and keep meeting them every time that we organize something. Thank you to him. Our Honorable Vice Chancellor, Professor Balvinder Shukla ma'am, for extending unwavering support to our initiatives. I also like to thank Dr. S.K. Srivastav, sir, mentor of IBHAS, for his overall support to our programs. I extend my gratitude to Professor Dr. Jayanti Pujari, ma'am, Dean, Rehabilitation Sciences Domain, for her constant support and guidance. A special acknowledgement to our Director of IBHAS, Professor Dr. Kalpana Srivastav, ma'am. I think it's because of ma'am that we've been able to take up CRE programs back to back also. And there are more events coming up in IBHAS. Please be ready and look out for them. And do join us for those programs as well. But ma'am's support and the motivation that she makes sure that we follow through things on time is why we are able to conduct these programs also. Ma'am, your dedication in planning has ensured that all our initiatives are knowledge enriching and impactful. Thank you for guiding us. I also like to thank Rehabilitation Council of India for allowing us to do meaningful CRE programs for skill building of clinical psychologists. At least we, I can say I personally feel that there are very limited CRE programs which are focusing on skill building of clinical psychologists. There are generic CRE programs that are being conducted, but we really would like to see more CRE programs where actual skill building of clinical psychologists is taken up.
And we thank CRE, RCI program, RCI for helping us do that. Furthermore, I would like to recognize the tireless efforts of all our faculty members at IBHAS. It is important to mention name of Ms. Sampurna Chakravarti, the coordinator for this program, how her commitment to follow through each step meticulously has played a crucial role in ensuring that this CRE program is successful. Thank you, Sampurna. I would also like to thank, a big round of applause for Sampurna, please. I would also like to thank IBA's admin team, Mr. Pavan, Mr. Sandeep, Mr. Sundar. Without their support, no event at IBA's can see light of the day. And their support at back end, you see the faculty members, but their support at back end really helps us. So thank you to them for this. I also like to thank the admin department, cafeteria team, IT department, audiovisual department from ASCO. Thank you for joining us every time and making sure that everything is done smoothly and our documentation is also well in time. Thank you for that. And I would like to now extend my thanks to very worthy and knowledgeable Dr. Prashanta Kumar sir for generously taking out time from his busy schedule, traveling in times of conflict that we are in, yet at the same time being here and such generously sharing his knowledgeable insights and making the CRE program far more meaningful by his presence over here. I'd like to thank all the speakers, in-house speakers, also Professor Dr. Kalpana Srivastava ma'am, Sampurna, Sneha, Rashmi ma'am, for also sharing so generously. And last but not the least, all the participants. This CRE would not be possible if you didn't register for it. So thank you for joining us for this program. With this, I conclude this ceremony. Please join us for high tea. Your certificates will be delivered. You can collect them from the registration desk. Please make sure to sign the last attendance sheet. These sheets go to RCI, and this kind of helps us complete the documentation also. All right. So we have CPSI conference. Everybody knows what CPSI is? The Society for Psychological Society of India, Clinical Psychology Society of India. We are having conference in November, 6th to 8th November in Amity University, the same campus. And it's an international conference, and we would like, ma'am, why wouldn't you come and just help understand? Because ma'am is at the forefront of organizing it, and we are just right now conceptualizing. We would really like ma'am to speak on this. Please, ma'am.
I can see the hustle and bustle because people are ready to move, but I'll just take a minute to say that we are planning to organize the international conference on in neurodiversity, not actually diversity and clinical psychology practice, and it is going to be from 6th to 8th November. And I really want that all of you come forward and be part of this event and join us here at Amity University. We will be circulating that in various groups about the information, registration, etc., participation, and looking forward to meeting you all there and welcoming you for that. And we are planning to have a good, I would say, speakers in terms of the panel of speakers, invited sessions, international speakers, and good content. So looking forward. That's all. Thank you.
Please join us for high tea and collect your certificates as you move out. Remember to fill all the evaluation sheets. Those sheets will ensure that RCI credits the CRE points to you all. Achha, you want to say something? Okay. Sampurna wants to call out some names for the people who have missed their signatures. Please make sure you sign the attendance sheets. Please make sure you fill the evaluation forms. These are the utmost necessary things.